This meeting to order. So welcome everyone to meeting number 45 of the House of Commons Standing Committee on Health. The committee is meeting today to study the emergency situation facing Canadians in light of the COVID-19 pandemic. Before I welcome the witnesses, however, I would like to draw the committee's attention to the supplementary budget request for this study. I believe all committee members should have a copy from the clerk. This request supplements our previously adopted budget for this study. It requests an additional amount of $4,125. This covers additional costs for witness headsets, video conferencing, shipping, and such. If there's any discussion, we can bring it up later. I'm hoping, however, it is the will of the committee to approve this budget at this time. Do we have unanimous consent to do so? Any dissent? Good. Seeing no dissent, thank you all. The supplementary budget is therefore approved. Thank you. So I would like now to welcome the witnesses. Appearing as an individual, nous avons le professeur Alain.
We have Professor Alain Lamarre, full professor, Institut National de la Recherche Scientifique.
Also as an individual, we have Professor Ambarish Chandra from the University of Toronto. We have Dr. Michael Silverman, Chair and Chief of Infectious Diseases at Western University. And from the Luma Medical Center, we have Dr. Michael Dumont, Medical Director, Family Physician. We'll start with questions. I will advise the witnesses that I shall hold up a yellow card when your time is in the vicinity of being over, and I'll hold up a red card when it's actually over. And if you see the red card, please do try to wrap up. Don't have to quit instantly, but do try to wrap up. Thank you. Nous commençons avec Monsieur.
We will begin with Mr. Lamarre. Go ahead, please, Professor. 5 minutes. Okay, thank you very much, Mr. Chair. First, I would like to thank the committee for the invitation to participate in this meeting. I would like to take a few minutes to discuss the importance of significantly increasing research funding in Canada, and in particular, fundamental research. I believe that this is a key issue in maintaining and increasing Canada's place on the global stage of health innovation. I am a full professor at the Centre Armand Frappier Santé Biotechnologie of the Institut National de la Recherche Scientifique, INRS, at Laval, where I have been studying the immune response to viral infections and vaccines for over 20 years. As a result, I have seen a relative decrease in research funding in Canada during this same period. Fundamental research is an indispensable component of the development of new technologies for the prevention and treatment of disease. For example, the mRNA technology that is the basis of Pfizer, BioNTech's, and Moderna's new COVID-19 vaccines was developed from the design of new approaches to cancer treatment. This means that the development of innovative approaches cannot always be accelerated by targeted, problem-specific investments, but often emanates from global investments in basic or fundamental research whose potential payoffs were often unsuspected at the outset. The business model of the pharmaceutical industry has radically changed over the last decades. Indeed, large pharmaceutical companies are increasingly relying on the public and academic sectors to develop new technologies instead of relying solely on their own research and development resources. For this reason, a rich and diverse public research ecosystem is increasingly important for the development and marketing of innovative new treatments for patients. The majority of biomedical research funding in Canada comes from the Canadian Institutes of Health Research. I am pleased. According to a recent analysis by the Canadian Association for Neuroscience using CIHR data, the success rate of applications to CIHR open competitions has steadily declined since 2005 from a success rate of 31% to less than 15% in 2018. Such a low success rate means that excellent applications are not funded and will have to be resubmitted, which imposes a significant additional workload on researchers and may even lead to the closure of successful labs especially for early career researchers. In addition to this low success rate in the CIHR project competition, funded applications are generally subject to budget cuts of more than 25%, which further demonstrates the glaring lack of funding. According to data from the OECD, Canada is the only G7 country where gross domestic expenditures on research and development have been declining since 2001 and is now second to last in the G7 on this measure, ahead of only Italy. For example, the United States invests more than 3 times as much in research as Canada per capita. This clearly demonstrates the considerable effort that must be made by Canada to become a world leader in this field. In order to contribute to the reflection on these strategic issues, I would like to propose 2 measures that the Government of Canada could consider to maximize the benefits of its investments in biomedical research. These measures are in line with recent recommendations from the Canadian Association for Neuroscience and the Naylor Report on Healthcare Innovation. First, federal investments in basic research in Canada should be increased by 25% now and by 10% per year for the next 10 years to catch up with other G7 countries. Second, federal investments in leading-edge research infrastructure through the Canada Foundation for Innovation must be continued and increased. We know that new advances in fundamental research require state-of-the-art infrastructure. These infrastructures entail significant operating and maintenance costs for researchers and universities. It will therefore be essential in the years to come to continue and increase investments not only in infrastructure, but also in the financing of their long-term operation and maintenance costs. In conclusion, the COVID-19 pandemic has highlighted the importance of having a rich and diverse ecosystem of fundamental research to better protect against future health crises. Canada will need to make a significant additional effort to become a world leader in research and development and invest heavily in research funding over the next decade. Thank you, and I am available to answer your questions.
Merci, Professor.
Thank you, Professor.
We go now to Professor Chandra. Please go ahead, sir. 5 minutes.
Good afternoon, and thank you for inviting me here today. I'm an associate professor of economics at the University of Toronto. My past and current research focus is on airlines and the US-Canada border. I've published articles in this area, and I've written a number of related opinion pieces in the media. I have previously provided testimony to Senate committees on the subject of airlines and cross-border travel. And my statement today is on Canada's policies towards the border and international travel since the start of the pandemic. In my opinion, Canada has made some correct decisions, but also some mistakes in its approach to the border. I'm sympathetic towards those who had to make quick decisions in stressful times, often with little available data or evidence. And so these remarks are not meant to be overly critical, but it is important to recognize the correct decisions as well as identify the mistakes to prevent them from happening again. Economists do not generally favor severe restrictions on international travel. My own research shows the huge social and economic benefits of travel. Yet, last year, I wrote to support the decision to stop non-essential travel between the US and Canada, and I still believe that decision was correct. I also believe that Canada's government correctly identified major essential sectors that were exempted from any travel restrictions. These were defined by Public Safety Canada and include categories such as food, water, health, manufacturing, and others. I believe mistakes were made and continue to be made in the mandatory testing and quarantine procedures for travelers entering Canada. Many travelers were exempted from quarantine or testing, including those who provide essential services, maintain the flow of essential goods or people, and those who commute for work or school. We correctly exempted these travelers from testing and quarantine, yet we continue to impose these requirements on a small minority of travelers for little purpose. To be clear, it was necessary to exempt truck drivers, other transportation staff, commuting workers and students, and anyone working in an essential industry. We have incredibly highly integrated supply chains with the United States. Our food networks, manufacturing supply chains, and deliveries of everything from medicines to construction supplies require regular cross-border travel. Trucks won't cross if drivers need to quarantine for 2 weeks. Everyday commuters cannot realistically quarantine, and healthcare staff should not be deterred from crossing the border. By my calculations, around 14,000 trucks enter Canada every day from the United States, which is about 5 million per year. I also estimate around 2 million car trips by commuters per year. When we add together the truckers, commuters, essential workers, and other exempt travelers, I estimate that over 80% of current cross-border travelers are not required to test or quarantine. Canadians have been led to believe that testing and quarantine at the border protects us from infectious disease and emerging variants. But in fact, these policies are weak. Consider, for example, returning snowbirds who cross the border by taxi, as they're permitted to do. The snowbirds, even if fully vaccinated, still need to test 3 times and quarantine for 14 days. Meanwhile, the taxi driver, who may well be unvaccinated, is not required to test or quarantine. Given this, there can be little doubt that viruses and their variants that are present in, say, the United States have made and will continue to make their way here no matter what. Why then do we require the remaining 20% of travelers to test and quarantine, and do so even when they have evidence of vaccination? Continuing to test and quarantine fully vaccinated travelers is extremely expensive for the government, time-consuming for CBSA, and onerous for travelers for no clear benefit. Canada's government is currently ignoring clear recommendations from its own expert panel to let vaccinated travelers enter freely and also to resume normal cross-border flows. This is baffling. Past governments have always supported the free flow of people and goods and opposed moves to thicken the border. Canada acted quickly in the wake of 9/11 to prevent the border from being closed and successfully carved out Canadian exemptions to American regulations, such as passport requirements and the Buy America provisions. Canada's policy has always been that a relatively open border is in the clear interests of Canadian citizens and businesses. It would be a massive miscalculation for Canada to continue restricting most forms of travel, given the low case numbers in both countries, especially as US lawmakers express their own bafflement and frustration at the continuing situation. At stake are not just the charter rights of citizens, but also the survival of the tourism industry, which employs, directly or indirectly, 10% of Canadians. At some point, Canadians can expect to see a commission of inquiry to examine Canada's response to the pandemic. While there are many aspects that will be evaluated, the government's handling of the air and land borders must receive special attention. I have no doubt that an inquiry will reveal both correct and incorrect decisions. We must record and acknowledge these in order to improve our future decisions. Thank you.
Thank you, Professor. We will go now to Dr. Silverman. Dr. Silverman, please go ahead, 5 minutes.
Thanks for the invitation to speak to you today. I would like to address the issue of healthcare worker COVID vaccination. Vaccination of healthcare workers has been an incredibly effective intervention in the control of COVID-19. A study from the Cleveland Veterans Affairs Department found that healthcare workers who had been vaccinated had a 19-fold lower risk of acquiring COVID than those who were unvaccinated. Furthermore, the institution suffered from 4 COVID outbreaks, all of which were associated with transmission from unvaccinated healthcare workers and no outbreaks from vaccinated workers. A recent outbreak involved a single unvaccinated healthcare worker who transmitted COVID to 20 other healthcare workers, 26 residents, and led to 3 patient deaths. This occurred despite the facility having extensive patient vaccination. In Canada, there's a wide variation in healthcare worker vaccination rates between institutions, with many having staff vaccination rates well below that in the general population. As having your personal healthcare worker being vaccinated can help protect you from exposure, these variable rates in vaccination raise an important issue of equity and healthcare delivery and patient safety. Many patients do not respond to the vaccine because of serious underlying conditions such as cancer, dialysis, organ transplantation, or other immunocompromising conditions. They are vulnerable and thus dependent on the healthcare workers and those around them to shield them from exposure to COVID. Unlike going into a private business, patients who need to go to hospital cannot simply choose to stay home. Therefore, we have a moral obligation to assure these people that we will do everything we can to prevent them from becoming catastrophically ill and dying while in our care. This then raises the issue of whether vaccination should be mandatory for healthcare workers who provide direct patient care. Several concerns about a mandatory vaccination policy have been raised. Firstly, due to personal privacy concerns, healthcare workers do not have to even report their healthcare information to their institution. Although it is true that the principle of privacy of healthcare information needs to be maintained, there are well-established exceptions where the public has a right to know in order to be protected. An individual struggles with alcoholism should remain a private matter. However, if that individual is a commercial pilot, the airline safety regulator has a well-established right to demand this information. In our own experience, many of us would not be comfortable having someone who was unvaccinated come into our home. However, when a patient is ill in hospital, they at present have no right to even ask whether the healthcare worker entering their room is vaccinated. The vast majority of patients would not consent to being directly cared for by a non-vaccinated person. However, this practice is still commonplace and is only able to be maintained because of a lack of transparency, which enables the system to deny this information to the patient. Patients have a right to expect that when they are being cared for in a medical facility, scientific principles will be used to determine the approach to care. We would not accept a healthcare worker making rules which have overwhelming consensus, and important patient safety issues must be maintained in order to provide a science-informed basis in care. I am not recommending that any individual who feels strongly opposed to vaccination must undergo it against their will. However, I do say that providing frontline healthcare services is a privilege, not a right. And if healthcare workers choose not to be vaccinated, despite the well-documented risks to both themselves and their patients, then hospitals should be able to decide not to allow their patients to be put at risk. These workers may be redeployed to non-frontline activities if possible, or if not, then terminated. Special arrangements for healthcare workers with vaccine allergy will have to be made, but true vaccine allergy is an extremely rare phenomenon. Our hospitals already mandate that healthcare workers provide proof of vaccination against other common transmissible agents, including measles and hepatitis B. Several countries have instituted mandatory health worker COVID vaccination policies. In the United States, the Equal Opportunity Commission has ruled that all companies can mandate employees to be vaccinated in order to protect their customers. Many large US hospitals have therefore undertaken a mandatory staff vaccination policy. In Canada, however, despite the fact that most healthcare leaders would like to institute such a policy, they have been hamstrung by concerns regarding the legal framework, including the Charter of Rights and Freedoms, and a lack of federal or provincial direction. Federal guidance and a national strategy on this issue is urgently needed. I therefore request that a committee be set up that would include representatives of healthcare institutions, healthcare providers, ethicists, patient advocacy groups, and legal experts. This would enable rapid development of guidelines regarding implementing mandatory COVID vaccination policies for frontline healthcare workers. Thank you.
Thank you, Doctor. We'll go now to Dr. Michael Dumont. Go ahead, please. 5 minutes.
Thank you. My name is Michael Dumont. I am Anishinaabe Martin clan. My family is from the Shawniga First Nation, and I also carry mixed European ancestry. I am calling from the unceded territory of the Musqueam, Squamish, and Tsleil-Waututh peoples, where I'm honored to make my home. I am a family physician and represent Luma Medical Center, where I serve as medical director. And I would like to thank the committee for the opportunity to speak today about urban Indigenous primary care in the COVID-19 pandemic. Indigenous peoples in Canada experience unacceptable disparities in health outcomes, and there continues to be a large unmet need for culturally safe medical care to address this gap. With this goal in mind, and guided by TRC Call to Action number 22, we established Luma Medical Center, an Indigenous-operated not-for-profit society, in 2016. Our center delivers safe, culturally integrated primary care for 1,900 Indigenous people in urban Vancouver, through a team-based, two-eyed seeing model, blending Western and traditional Indigenous approaches to health and healing. We've been fortunate to build excellent partnerships with the First Nations Health Authority, Vancouver Coastal Health, and our provincial health ministry in developing our community-guided service plan, which funds our interdisciplinary team. The support from our local MP, Don Davies, and our provincial MLA and Health Minister, Adrian Dix, have been invaluable. However,
Monsieur le Président.
Excuse me, Mr. Chair. I'm
En anglais. Je réalisais pas que la traduction ne se faisait pas. Donc, vraiment,
I didn't realize that the interpretation wasn't working. I can only understand. I'd like to request the French interpretation.
Yes, I'll ask the.
il n'y a pas de problème. Merci.
Thank you.
Check on that.
Oui, je
That's
l'entends
good.
maintenant.
I can hear it now.
Doctor, maybe back up a couple paragraphs and start
Certainly.
over. Thank you.
okay, absolutely.
I'll give you a little more time to accommodate. Thank you.
Mr.
No problem
Chair,
at all.
especially the part where you mentioned me. I'm teasing.
We're going to edit that out anyway, so that's fine. Anyway, go ahead.
Okay, thank you. Indigenous peoples in Canada experience unacceptable disparities in health outcomes, and there continues to be a large unmet need for culturally safe medical care to address this gap. With this goal in mind, and guided by TRC Call to Action number 22, we established Luma Medical Center, an Indigenous operated not-for-profit society in 2016. Our center delivers safe, culturally integrated primary care for 1,900 Indigenous people in urban Vancouver through a team-based two-eyed seeing model, blending Western and traditional Indigenous approaches to health and healing. We have been fortunate to build excellent partnerships with the First Nations Health Authority, Vancouver Coastal Health, and our Provincial Ministry of Health in developing our community-guided service plan, which funds our interdisciplinary team. The support from our local MP, Don Davies, and our provincial MLA and Provincial Health Minister, Adrian Dix, have been invaluable. However, we stand in a difficult position. We are facing unprecedented demand for our primary care services, fueled by the overlapping health emergencies of the COVID-19 pandemic, the opiate overdose epidemic, and Indigenous-specific racism in healthcare. We have run out of physical space in our building to meet the needs of our growing patient panel and seek financial support to make the necessary capital improvements to an adjacent unit in our building to expand our services. With this plan expansion, we plan to build 2 additional medical exam rooms, a physiotherapy gym, a sacred space for group healing and ceremony, a traditional medicines room, a culturally integrated pharmacy, and 3 counseling rooms. These improvements will allow us to fully expand to the full realization of our service plan, attaching 2,800 First Nations away from home and urban Indigenous people to culturally safe primary care. We have fundraised $60,000 through local and provincial partners, but need an additional $160,000 to complete this capital project. It is exceedingly difficult for Indigenous health organizations such as ours to access capital funding to develop needed projects like this off reserve, where the majority of Indigenous people, status, non-status, and Métis live. We call for a partnership between Indigenous Services Canada and the Ministry of Health to develop a funding stream for capital grants to support the development of Indigenous-specific health centers off reserve. This mechanism could provide enormous benefits for status First Nations and other Indigenous people living in urban centers and away from their home communities, and to help the federal government meet its commitment to closing the health gaps between Indigenous and non-Indigenous people in this country. Secondly, I'd like to highlight how we have responded to local care needs during the COVID-19 pandemic. We are currently the sole Indigenous-specific COVID-19 vaccination site in the city of Vancouver, providing cultural support services through the full vaccination experience. Of the 10 mass vaccination clinics completed or scheduled, 7 have had bookings handled under the provincial booking system. At these clinics, only 1 to 29% of attendees were Indigenous. As non-Indigenous people, we're still able to book appointments and displaced our community members who sought the familiar, safe environment of our center for their vaccinations. In the subsequent 3 pilot clinics where the bookings have been coordinated directly by our organization, 99% of vaccines have gone directly to Indigenous community members. We see this as a major success in overcoming vaccine hesitancy and improving immunity in our urban Indigenous population, which faces higher rates of COVID-19 infection, hospitalization, and death compared to non-Indigenous Canadians. We advocate for Health Canada and Indigenous Services Canada to build more direct partnerships with urban Indigenous organizations such as ours, who have earned the trust of our local communities for the safe and effective delivery of COVID-19 vaccines to Indigenous people off reserve. We believe this approach will lead to higher vaccination rates and improved health outcomes compared to the current reliance on provincial or territorial partners for all off-reserve vaccinations for Indigenous peoples. Thank you very much for your time and opportunity to share the story of Luma Medical Center at this forum. Aichko Siem Chimigwech, all my relations.
Thank you, Doctor. We will start our questions at this point. We will start with Ms. Grimple-Garner, please. Go ahead, 6 minutes.
Thank you, Chair. I'll direct my questions to Dr. Chandra. Thank you for your testimony today. Maybe I'll start by just asking you if you're aware that the federal government extended the U.S.-Canada land border closure for another month today.
Yeah.
Maybe I just give you a minute to talk about the impact of that in the context of the piece that you wrote in the Globe and Mail recently.
I have to say it's disappointing, and also it's a little bit bewildering. It's not clear, at this stage what threat we face from especially fully vaccinated Americans, but fully vaccinated people from, in general, the rates of community transmission in the United States are either comparable to ours or at times lower. Both New York State and Michigan, our immediate neighbors across Ontario, which has the busiest land borders, have lower rates of infection than we do. If we're going to continue to keep the borders closed now, then maybe we should never open them, because there will always be diseases, not just COVID, but others. And so I find it baffling that, especially today's decision, in the light of the high vaccination rates and the low case numbers.
I do as well. And the committee is trying to ascertain whether or not the policies that we have in place are beneficial to Canadians at this point. You just alluded to the fact at this point you couldn't point to a specific body of evidence that shows the benefit of this policy. You don't have to comment on this. I'm speculating that it is political at this point in time. But maybe I think the other side of the equation on the land border closing right now really hasn't been discussed, and that's the opportunity cost to industry. I know that there's a lot of people who are, for example, flying into Buffalo and then driving across the land border. So those rules are kind of being skirted in some ways anyways. Can you perhaps try and quantify for us the potential opportunity cost of closing the U.S.-Canada land border for another month without this evidence of necessity?
One thing I just say is, the fact that some people skirt the rules isn't necessarily evidence of failure. We design public policy all the time where occasionally people do slip through the cracks and evade restrictions. As long as they work most of the time for most of the people, it's still good to design public policy with good aims. But now you asked me to quantify the effects on industry. To some extent, we won't know until much later. We won't know till months or years later exactly what effect this will have on industry. But I can tell you that the tourism sector in Canada, broadly defined, employs 10% of Canadians, directly or indirectly. That's a staggering number. Now, of course, a lot of that is domestic as much as international travel, but a lot of these are crown jewels of tourism will not survive without international travel. Niagara Falls, Ontario, Whistler, BC, Banff, Lake Louise. These destinations will not be able to keep operating in the future if we essentially make clear that we aren't interested in foreign travel, especially by people who are, completely safe, fully vaccinated. So I can't give you a number on.
I just have a couple of minutes, so sorry to interrupt you. And I would invite you to table any research that you have to this regard with committee. It would be very helpful for our deliberations. I'm just wondering, again, I'm trying to get to a quantification of this. Could you ballpark a dollar amount or a number of jobs that the Canadian economy is now losing, let's say, per month, for every month that border closure is delayed without a plan in sight?
I'd be very reluctant to ballpark a number. I can try to come up with an estimate and send that to your office or to the committee later on. And I do think even the best estimate right now might prove to be wildly off once we fully realize the effects of this in the future.
Again, it is at this point, as a legislator, without seeing data that shows that there is a considerable public health benefit to keeping the border closed at this point. And I'm very open to looking at that data, which has not been provided by the government to this committee. I am kind of surmising that this is a political decision at this point. Would you want to speculate on that, or perhaps on the reason that you would think that this is still in place?
I do think that there's been, I can see very clearly, living where I do in Toronto, that there's pressure from the provinces, certain provinces, with the claim that borders are a cause of infection. And I think it's, multiple levels of government find it convenient to toss that football around, but there's no evidence for it.
In your piece with the Globe and Mail, you said that Europe is already vaccinating or welcoming fully vaccinated Americans. Are there any other international examples that you would point us to in terms of best practice right now?
Well, so as of last week, France and Spain have begun welcoming fully vaccinated travelers. I believe Finland announced today that they would, as of today. I, again, can probably look up a list of jurisdictions and let you know.
Last question. Today, Perrin Beatty made a comment that it is now easier to fly to France for a fully vaccinated Canadian than it would be to go to Buffalo. Would you agree with that assertion?
I mean, it's true. The fully vaccinated Canadians are welcome in France, but they're not necessarily welcome back today without quarantine.
Do you think that that will have a significant detrimental impact on many different industrial sectors in Canada?
Absolutely. It's in fact, there are so many sectors. I mean, we take for granted that people can cross the border and take advantage of tourism opportunities here. I think when we finally see the scale of the effect, we'll be shocked.
And would you recommend the reopening of the US-Canada border with whatever safe provisions that you might recommend at this point?
I mean, frankly, for fully vaccinated travelers, that time has long passed. It should have been true in April, but regular resumption of cross-border flows, I think, is overdue even today.
Thank you.
Thank you, Ms. Rempel-Garner. We go now to Dr. Pawlowski. Dr. Pawlowski, go ahead, please. 6 minutes.
I'll address my questions to Dr. Silverman. So thanks for a very cogent, well thought out argument as to why we should be considering making COVID vaccination mandatory for...
I'm sorry, I can't hear Dr. Pawlowski.
Can anybody else not hear me, or?
Doctor, maybe lift your mic. Let's check.
Actually, I couldn't hear I couldn't hear Dr. Chandra either, so it's possible there's something wrong on this side.
Can you hear me now, Mike? Can you hear me now? Should I keep talking? Can you hear me or no?
We're going to suspend for a minute as we sort this out. So the meeting is suspended. Due to problems with Dr. Pawlowski's microphone, we will go directly to Monsieur Lemieux.
Sorry, Mr. Chair.
Lemieux, I'm sorry.
Merci, Monsieur le Président.
Mr. Chair, sorry.
Un moment, s'il vous plaît.
Just a moment, please.
Miss O'Connell, is it, I believe?
Yeah, thanks.
On the point of
sorry,
order?
I don't think it's an issue with Dr. Pawlowski's microphone. I think we have a witness who can't hear the testimony, and so that's not fair to any members who might want to ask him a question and he's not able to hear. So I think we need to sort out why this one witness can't hear any of the interventions.
Point of order, Chair. On that point of order, we have very limited amount of time in this panel. It seems to be a technical issue with the witness in terms of his microphone. If my colleague, Mr. Lemaire, is not intending on asking Dr. Silverman questions, then I would suggest that we proceed while IT deals with Dr. Silverman's IT issues so that the rest of the committee is not wasting time, which is greatly unfair to everybody, given that it is a technical problem on one witness's end.
Thank you for all of your points of order. Dr. Pawlowski has already agreed to ask his questions in the next slot, so we will carry on. Nous allons maintenant,
And now, Mr. Lemire. Go ahead, please, Mr. Lemire. You have 6 minutes. Thank you very much, Chair. It's a pleasure to discuss with you witnesses today, especially Mr. Lamar, who was at the Industry Committee a few months ago. It's interesting to hear from him about the evolution of research and the importance of research these days. Mr. Lamar said that fundamental research is essential. It can improve the lives of Canadians. He said that it's essential to invest continuously in fundamental research as a social expenditure. Do you agree? And can you explain? Answer. Yes, absolutely. This is an excellent point. As you have said, fundamental research is an investment in developing the technology of the future, an investment in innovation in healthcare. Fundamental research is important to many domains and sectors, but especially for health. Fundamental research permits us to develop new therapies and eventually new treatments, new drugs, medications. Over the past decades, there has been a slowing down, even a decrease, in investments in research and funding. We've seen the consequences that that can have, for example, in developing vaccines. Newspapers reported that Canada lost a lot of ground internationally in its capacity to develop and produce vaccines. I think it's time to invest heavily in fundamental research in order to rebuild the entire ecosystem and to be better placed similar to other countries. Question. Yesterday, we learned that the microbiologist Gary Kobinger, a very well-known microbiologist, he, in fact, left his position in Quebec to go to the University of Texas because there's more funding there. Over the past 20 years, there has been chronic underfunding. Will we experience brain drain? How can we stop this brain drain in the future to make Canada an attractive place for scientists? Answer. This situation is really a shame. He's not the first to leave Canada, and he won't be the last either. Neither the first nor the last to leave Canada for research positions with better funding, be it in the United States or in Europe. Over the past years, there has been a drop in highly qualified professionals from 9 per million per 1,000 to 8 per 1,000. That is a substantial decrease in the number of researchers working in Canada. Moreover, when it comes to funding opportunities, there are a lot more funding opportunities in the United States. As I've said, the United States invests 3 times more in R&D than Canada does. As a result, Canada's top talents are very attracted to the opportunities there. It's very worrisome. Question. In your speech, your second recommendation was to continue to invest in research infrastructure through the Canada Innovation Fund. Could you expand on this, please, so that we can ensure that the government can and does invest more in innovation? Answer. The Canadian Innovation Fund is a great tool, I must say. It's a great tool in Canada. The fund makes it possible to have cutting-edge infrastructure. Such infrastructure allows us to be leaders in fundamental research. However, this fund is always at risk of being cut or reduced, which causes stress. We must also consider the operating costs of these infrastructures because the infrastructure's operating costs are rather high. and the Innovation Fund does not cover all of those costs. We must increase funding for infrastructure as well as operating costs and maintenance costs of the infrastructure. Question. You spoke of the ecosystem of research and life sciences ecosystems. Mr. Clark told us that in 5 years, there hadn't been an impact study on life sciences in Canada. Many witnesses have told us about the weakening of Canada's biosciences sector. We thus expect that there will be negative consequences in Quebec for all parts of this ecosystem. Does this concern you, sir? Answer. Well, it's complex. I understand the advantages of decreasing the costs of medications for Canadians. That's complex, and we do have to study that. But we must look at the issue as a whole. We should not concentrate exclusively on cost, but also we should consider the value of innovative drugs and medications. We should also consider the impacts on research. So we must really look at this from all angles. Thank you, sir. Thank you, Mr. Lemire.
We were going to go back to Dr. Pawlowski, but I believe Dr. Silverman is on the phone with IT support. Dr. Silverman, are you able to hear me?
Yes, I can hear you. The question is whether I'll be able to hear Dr. Pawlowski.
Can you hear me? Can you hear me, Mike?
Now I can. That's great.
Okay, perfect. So
that's great.
I want to start off by congratulating you and telling you I think you did a very good job of making a very good argument that COVID vaccine should be mandatory for healthcare workers, and perhaps there's a need for national leadership with recommendations on this subject, perhaps under the auspices of PHAC. But I want to switch to another topic, in that is the issue of whether or not we should be keeping schools open given the number of COVID cases. You recently wrote a paper that I think was published in the Canadian Journal of Public Health entitled The Ethics of COVID-19 Related School Closures, where you talked about the pros and cons of school closures and who ought to be making the decisions as to whether or not to keep the schools open. Could you maybe summarize your conclusions in that paper? Thank you.
Thanks. The issue of school opening and closures has been highly debated. There is, however, strong consensus that because of both the short and long-term developmental and mental health risks of missing in-person learning and the low likelihood of severe physical harm to children from COVID, the safest place for children is in school. However, these considerations must be balanced against the health risks to teachers of in-person learning, as well as the potential health risks to parents and the overall trajectory of community transmission. These are all medical questions. They involve triaging between various medical priorities and therefore are best decided by the medical officer of health. I would differentiate these issues from political concerns such as business closures. In the setting of closing the economy, economic bailouts and mitigating strategies which involve the public purse can be employed, and so the politicians have an important role in decision making. In contrast, school closures are purely a matter of triaging healthcare priorities. No amount of economic bailout can compensate a child for changes in their long-term development. Politicians are subject to community advocacy pressures, which should not impact decision-making on the best approach to maximize public health. Promises are commonly made that schools should be the last thing to close and the first to reopen. However, in practice, this doesn't happen due to strong political pressures by various advocacy groups. Data from the United States shows that with the same level of community transmission, states run by Democratic governors were much more likely to have closed their schools than states run by Republican ones. Decisions about school closures should be apolitical and made by the public health system with the same separation of decision making as occurs with the Justice Ministry. This would assure that public health priorities remain paramount.
Thank you. Now, turning to one of my favorite topics, and I'm sure the committee as a whole, the issue of the use of monoclonal antibodies. Dr. Silverman, are you using them at Western? Do you find them helpful? And why aren't more Canadians using them?
So we are using them at Western, but it's been we've been hamstrung by a couple of things. First of all, there's been very slow. There's one monoclonal which is available, bamlanivimab, a combination of monoclonals which has just been approved by Health Canada, but still is not available. And as we're getting more variants, we need these other options. They are available in the United States. They've been available for quite some time. They really help some people who who are at risk for developing severe COVID due to severe underlying conditions. They're not a panacea, and they are difficult to administer because they need IV therapy for people who are generally well at the time when they need it, but are at risk to get very sick. And so we found that it's extremely difficult to get a hold of, and but the difficulties can be overcome. With Health Canada's recent approval of combination drug, which has been quite honestly very, very slow and very late, and there are multiple other options available in the US that are not being made available in Canada yet. And also, but with that, at least development, we need rapid deployment of the drug so that people who need it can get it. And we also need institution of infrastructure so that it can be administered to outpatients rather than having them come into the hospital to get it. So special outpatient facilities as exist in the United States have been set up, which have enabled hundreds of thousands of people to be treated in the US, but not yet in Canada.
Now, what would be your response to people who say, well, we're getting lots of vaccines now, we don't need the monoclonals anymore? Is that the case, or is there going to be still an ongoing need for monoclonals and other forms of therapy in the coming months?
So because more and more people are getting vaccinated, the need will decrease somewhat, but it is by no means going away. Many people don't respond well to the vaccines, such as people with underlying immunocompromising conditions, and we are seeing these people come down with COVID despite being vaccinated. And we're also seeing people who have only had one dose of vaccine now getting sick with the new Delta variant and other variants. And that's going to continue to happen for some time. And those people are important, and we need to be able to service their needs to prevent them ending up in hospital.
I see a wavering red card there. How much time do I have?
You have 30 seconds.
Quickly, Mike, do you have any comment on what further we ought to be doing in terms of protecting healthcare globally? We've both worked internationally in healthcare. Are healthcare workers in developing countries getting the vaccine and getting protected?
I have a number of colleagues across sub-Saharan Africa. They are all complaining of limitations of availability of vaccine. They say in theory, the government says it's available, but when you go, the cupboards are bare, and they have to wait prolonged periods of time for either the first dose or the second dose. And basically, the cupboards are bare in many of these places.
Thank you, doctors. We'll go now to Mr. Davies. Mr. Davies, go ahead, please, 6 minutes.
Thank you, Mr. Chair. I'd like to thank all the witnesses for being with us today. Dr. Dumont, if I may direct my questions to you. First, let me just say for the benefit of all of the committee how exceptional the Luma Medical Center is. It is an Indigenous-led community clinic in Vancouver, serving primarily Indigenous urban population that is innovative and delivering frontline care, primary care to people who largely don't access that. So just want to congratulate you on your accomplishments to date. Dr. Dumont, I wonder if you could describe in a little bit more detail for us what impacts you've seen over the past year and a half since the pandemic started on the client population. I guess it's primarily Indigenous, urban Indigenous people, and what you could tell us about that.
I'm so sorry, Don. I don't know if it's my connection or yours, but I missed the question.
Can you hear me now, Dr. Dumont?
I can hear you now, yes.
Okay. Mr. Chair, I'm wondering if I could just have that time back. And Dr. Dumont, I was asking if you could perhaps describe in a bit more detail what impact you've seen on your patient population, namely sort of urban Indigenous people over the course of the pandemic.
Mr. Davies, I did stop
Absolutely.
your time for you to re-answer the question, and I will start it again now. Thank you.
Thank you, Mr. Chair.
Go ahead, Doctor.
Yes, so I very much appreciate the opportunity to answer that question. It's been an exceptionally difficult time for our patients, especially for Indigenous people living off reserve. I do work as well with the Musqueam First Nation, doing on reserve primary care, and I think the pandemic has been especially difficult for Indigenous people off reserve because they haven't had the same opportunities for to safely safely stay home and safely quarantine. Many of our urban families are living in very crowded environments, and this shows up in the data. We've seen higher rates of infection, higher rates of hospitalization, and higher rates of death among Indigenous people living off reserve. I believe that's all across Canada, but certainly true here in BC. I'm sure the committee is aware of the recent In Plain Sight report in BC. So a report into Indigenous specific racism in the healthcare system here in BC. This is certainly not a situation that's unique to BC as well. Healthcare spaces are in general a very difficult place for Indigenous people to access at a baseline. There unfortunately is still very much a culture within healthcare spaces that is very toxic and not very welcoming for Indigenous people. And for many of us, we don't have a sense of safety walking into these environments, be it a walk-in clinic, an emergency room, or a community health center to seek the care that we need. Add to that the burden of the pandemic and the difficulties of accessing care safely, from an infectious disease point of view, and it's meant that a lot of our patients are even further isolated from the care that they need. So I would say that just further increases the need for centers like ours to be able to provide that culturally focused care, that safe care. The majority of our healthcare providers are Indigenous. The ones that aren't are very strong allies that have had cultural safety training and have developed those trusting relationships with our patients too. So we've been doing certainly more virtual care and trying to do more sort of safe outreach care to our patient population, and working very hard to vaccinate as many people as we can in the community. Certainly it's been an exceptionally difficult time over the last 15 months.
Thank you. Dr. Dumont, you used the phrase culturally informed care. I'm wondering if you could describe to us a little bit more about what you mean by that.
Mm-hmm. So I use the term culturally safe care, and the reason I use cultural safety specifically is it places the interpretation of and sense of safety from the patient's point of view, and that's a very important distinction. We've talked in the past about cultural competency as a concept of learning about some of the historical factors that affect Indigenous people accessing care. That competency is a necessary component to that education for all healthcare workers, but it's not complete. Cultural safety again is a concept that takes that a step further and asks or at least it places the perspective more on the patient side as far as how they feel in that interaction. And it basically means that we have a responsibility as healthcare providers to make sure that the interactions that we have with our patients, the procedures that we conduct, any of the care that we provide is done in a manner that first of all helps the patient feel safe, feel cared for, free of discrimination, and a place where they feel that they can build trust. We spend an enormous amount of time, especially early in our interactions with patients and their families, on making sure that it is a safe space, and building those trusting relationships off the start, so that they have that sense of trust coming to the healthcare system. We see that as fundamental. That relationship really is the intervention at the beginning when we're getting to know them.
Now, I know we have historically a very physician-based care model, and I think we're now increasingly aware of the importance of allied health professionals to provide a whole approach to patient care. At your clinic, I know that you have incorporated some novel and creative use of people like elders and use of Indigenous traditions and ceremonies as a way of treating people with mental health issues, I think. Can you maybe elaborate a little bit on your clinic's experience with that?
Absolutely. So we partner with Indigenous elders and traditional healers. They are part of our team. They are hired on and full members of our team. We know from patients themselves and their families, but also from research that the inclusion of elders on primary care teams improves mental health outcomes, not only subjective scores in terms of depression and anxiety going down, but also reduced risk for suicide, reduced risk for involvement in the criminal justice system. There are a number of benefits, and just from a from a staffing point of view, it's made an incredible difference just in terms of how we provide our medical care.
Thank you, Mr. Davies. So that wraps up our round of questions. I think we have a couple of minutes for a quick snap around if people are interested. So not very much time, so let's give 1 minute per party. And I believe we would start with Mr. Barlow. Mr. Barlow, go ahead, please. 1 minute.
Thank you very much, Mr. Chair, and I'll be fast. Mr. Chandra, I was surprised with the words that you used regarding the border closure. But one thing I wanted to ask you, you were talking about this being baffling and bewildering, but in the supplementary estimates, the Liberal government is asking for an additional $1 billion with a B for hotel quarantines, and they've already spent $225 million. Do you think that is a good investment to continue these hotel quarantines for an unspecified amount of time if we shouldn't even have the border continue to be closed?
Absolutely not a good investment.
You also mentioned about the fact that, if we're not going to open the border now, why bother opening it at all? I thought that was an interesting, but they may never be opened. Can you elaborate on that really quickly, if you don't mind?
I just think I realize now that it's easy to impose these restrictions and very difficult to lift them. But let's look at the example of Australia. They've had borders closed since the start of the pandemic, and now they're saying they're not going to open them at least until the middle of next year. And so, and I guess we'll see what effect that has in the long run in Australia on the universities and their tourism sector and all of that. But I hope we don't treat the border so casually here. We just can't afford it.
Thank you, Mr. Barlow. We go now to Dr. Pawlowski, I believe. 1 minute, please.
Thank you, Dr. Silverman. As you may know, I think 70-something of us members of Parliament recently signed a letter supporting the idea of waiving intellectual property rights related to COVID that's being done at the WTO level. Can you comment on that and what you think of the importance of that in our globally trying to manage the pandemic?
Thanks. I think it is the right thing to do. I think that, the experience from the HIV epidemic is that intellectual property rights really slowed the delivery of antiretrovirals. We do have large production facilities, several places in the developing world that could ramp up if intellectual property rights were waived. There can be mandatory licensing. This should not affect the companies because they can be produced for distribution in the developing world exclusively at cost. There can be with mandatory licensing some compensation to the companies, and it's the right thing to do, and it would protect us by having rollout in countries that for the foreseeable future will not be able to pay the market price for these vaccines.
Thank you, Doctor. On va maintenant à Monsieur Lemire.
We go now to Mr. Lemire. Mr. Lemire, go ahead, please. 1 minute. Thank you, Mr. Chair. Mr. Lamar again. On February 18th, 4 months ago exactly, you came to the Industry Committee and you talked about the traps we needed to avoid. You told me we needed to not focus on a too small number of technologies based on current issues. We need to look at things more broadly, and we need to maintain strong fundamental research capacity. We know that the mRNA technology was developed over 40 years ago with other research, and it's saving us today. Based on the past 4 months, have things changed? Is the government keeping its promises? Things are starting to change. There have been investments, ad hoc investments, in some biotechnologies, pharmaceuticals, at a small scale. We've started to see the benefits. There's Medicago in Quebec, which is now conducting its phase 3 clinical trials. There are also other technologies in BC and Alberta, for example, that were helped. However, much more needs to be done. By my estimates, we'd need to double the budget for basic research over the next 10 years. Do you feel that there's a long-term vision at the moment? I don't have that impression. Thank you, Mr. Lemire. Thank you.
We go now to Mr. Davies. Mr. Davies, go ahead. 1 minute, please.
Dr. Dumont, I know that Luma Medical Center profoundly understands the importance of social determinants of health, and you have partnered with the Luma Native Housing Society, and according to their website, there are over 3,500 individuals and families on Luma's wait list for housing with subsidy. People wait many years before landing housing with subsidy provided. I'm wondering if you could briefly describe the importance of housing and the impact it has on health in your patient cohort.
Housing is critical. I'd sort of think of it as the first, the primary social determinant of health. We start with housing as our first intervention. If we have a patient coming to see us for the first time who is experiencing homelessness or is underhoused, and we're fortunate to work with a partner organization like Luma Housing to be able to connect our patients with that support. And part of our interdisciplinary team is having social navigators to actually help with housing applications, treatment program applications, and
Thank you so much for your fabulous work.
Thank you, Mr. Davies. And thank you to all of the witnesses. On behalf of the committee, I certainly want to thank you for all your time, all of your effort in sharing with us your expertise and helping us with our study, and certainly for what you do on a day-to-day basis to move us forward. So thank you all. And with that, we will suspend and bring in the next panel. Thank you. meeting back to order. We are resumed. Welcome to the second part of meeting number 45 of the House of Commons Standing Committee on Health. The committee is meeting today at this point to study the supplementary estimates A 2021 to 22, votes 1A and 5A under Canadian Food Inspection Agency, vote 5A under Canadian Institutes of Health Research, votes 1A and 10A under Department of Health, and votes 1A, 5A, and 10A under Public Health Agency of Canada. I would like to welcome the witnesses appearing today with us. We have the Honorable Patty Hajdu, Minister of Health, and appearing with the Minister, we have with the Canada Border Services Agency, we have Denis Vinette, Vice President, Travelers Branch. For the Canadian Food Inspection Agency, we have Dr. Sidika Mitani, President. For the Canadian Institutes of Health Research, we have Dr. Michael Strong, President. From the Department of Health, we have Mr. Stephen Lucas, Deputy Minister. With the Department of Public Safety and Emergency Preparedness, we have Ms. Monique Beauregard, Associate Deputy Minister. And from the National Advisory Committee on Immunization, we have Mr. Matthew Tunis, Executive Secretary. And with the Public Health Agency of Canada, we have Dr. Teresa Tam, Chief Public Health Officer, Mr. Ian Stewart, President, and Brigadier General Krista Brody, Vice President, Logistics and Operations. With that, I would invite the Minister to present a statement. 10 minutes, please.
Thank you very much, Mr. Chair, and thank you for the opportunity to appear before all of you today to speak to the supplementary estimates A for the health portfolio. First of all, I'll just thank the committee for their exceptional work over the last several months as Canada responds to COVID-19 and the pandemic. Your diligent oversight is key to ensuring we continue to work effectively together to protect Canadians during the pandemic and beyond. And COVID-19 continues to dominate our work in the health portfolio, and it's therefore the driving force behind the spending plans I'll outline for you today. So today I'm joined by Dr. Stephen Lucas, Deputy Minister at Health Canada, Ian Stewart, the President of the Public Health Agency of Canada, Dr. Teresa Tam, the Chief Public Health Officer, Brigadier General Krista Brody, Vice President, Vaccine Rollout Task Force, Logistics and Operations, Dr. Sidika Mitani, President of Canadian Food Inspection Agency, Dr. Michael Strong, President, Canadian Institute of Health Research. And so I'll start with an update on our ongoing response to COVID-19. It's, I think, pleasing for everybody to see that disease activity continues to decline across Canada. We're seeing fewer new cases, and the number of people who are severely ill is also decreasing as overall infection rates come down. At the same time, the vaccine supply continues to increase, making it possible for more and more Canadians to get their first and second doses. As of earlier this month, there was enough Moderna vaccine delivered to the territories to fully vaccinate 85% of the adults who live and work there. In total, 29 million doses of vaccine have been delivered over Canada, and I do believe that's probably outdated a bit as of today. As a result, more than 70% of eligible adults in Canada have already received at least one shot. These trends are encouraging, and of course, increased vaccination combined with strict public health measures are working. The national case count is now at its lowest level in weeks, and we are hopeful that the summer ahead will be a safer and healthier one for all of us. Nevertheless, we are at a critical junction in the pandemic. As immunity builds across the population, we have to continue to work to keep those infection rates low so that everybody has a chance to get fully vaccinated. And this is particularly important with more transmissible variants of concern circulating in most provinces and territories. And that's why for the time being, we're asking all Canadians, whether they're vaccinated or not, to continue to follow their local public health guidance. Some extra caution now will set the stage for a safe reopening in the months to come and a resumption of our lives, hopefully with a resumption of our capacity to have more normal activities in the fall. In the health portfolio, we're focused on keeping Canadians healthy and safe as we navigate this precarious moment in the pandemic. And the supplementary estimates I'm presenting today support this commitment. Given the shifting nature of the pandemic, we've realigned some of our resourcing plans to better support our evolving work. In total, I'm seeking an additional $5.5 billion on behalf of the health portfolio, which includes Health Canada, the Public Health Agency of Canada, the Canadian Institutes of Health Research, and the Canadian Food Inspection Agency. So beginning with Health Canada, through these supplementary estimates, Health Canada will receive a net increase of just over $1 billion. This amount, which includes both new funding and funds reprofiled from last year, will go primarily towards Canada's COVID-19 response. And this includes investments to strengthen the long-term care sector, improve virtual care and digital health tools, and safely restart the economy. These estimates also include funding to support Health Canada's ongoing work in other areas, including $53.5 million for Canada's chemical management regime, $27 million to extend the Territorial Health Investment Fund, and $14.25 million to support the Mental Health Commission of Canada. Also included is just over $15 million for employee benefit plans. The Public Health Agency of Canada continues to focus on mounting a robust response to the COVID-19 pandemic. And through these supplementary estimates, the agency is proposing an increase of just under $4.4 billion. This includes both new and reprofiled funds. Most of these funds requested will support the ongoing response to COVID-19, including research and vaccine developments, border and travel measures and isolation sites, medical countermeasures, and testing and contact tracing and data management as part of the Safe Restart Agreement. Some funding will also go towards Indigenous early learning and childcare through the Aboriginal Head Start program, as well as to Canada's chemical management regime. Next, I'll turn to the Canadian Institutes of Health Research, which is seeking an increase of approximately $111 million in these supplementary estimates. This investment, resulting from a reprofile of the medical countermeasures phase 3 funding from 2020 to 2021, help address persistent and emerging gaps in the research on COVID-19 and priority areas such as variants and long COVID. Finally, I will speak to the Canadian Food Inspection Agency, or CFIA. As you know, the COVID-19 pandemic has put a great deal of pressure on Canada's food production and supply chain. With this in mind, CFIA is proposing a net increase of just over $35 million to help safeguard the integrity of Canada's food safety system. This includes an increase of $28.7 million to increase food inspection capacity and maintain a daily shift inspection presence in federally registered meat processing establishments. It also includes $6.4 million to support employee benefit plan adjustments. Mr. Chair, as I said, this is a key moment in the pandemic, and the government's top priority remains protecting Canadians' health and safety. With continued care, caution, and vigilance, we will set the stage for a safe reopening and a return to all of the activities that we have missed over the past year. The supplementary estimates I've presented today will support the important work that must take place before, during, and after that transition. So my colleagues and I are happy to take your questions. Thank you, Mr. Chair.
Thank you, Minister. We will start our questions with Ms. Rumpel-Garner. Ms. Rumpel-Garner, please go ahead, 6 minutes.
Thank you, Chair. Mr. Stewart, are you aware of the House of Commons motion which was passed in the House yesterday regarding you?
Mr. Chair, honorable member, yes, I'm aware of the motion that was passed in the House of Commons.
So there were two components to the privileged motion passed yesterday, requiring you to attend, through you, Chair, Mr. Stewart, to attend the bar of the House after question period on Monday, to receive an admonishment to be delivered by the Speaker, as well as to deliver up documents ordered by the House on June the 2nd, so that they may be deposited with the Law Clerk and Parliamentary Council. Mr. Stewart, do you intend to comply with both components of that motion on day?
Mr. Chair, honorable member, the motion is with respect to Monday. And for those of us who are working on the COVID pandemic, that's a while from now. I'm aware of the motion and what it requires of me. And I look forward to Monday as it comes.
Are you aware that Parliament is supreme and that your opinion is immaterial in this regard?
Mr.
Point
Chair.
of order, Mr. Chair.
Ms. O'Connell on a point of order, go ahead.
Sorry, Mr. Chair, the relevance of this questioning, given the fact that this meeting is either on supplemental estimates or COVID, and suggest, Mr. Chair, that you rule that the member stick to the topic of the meeting.
I certainly would recommend to all members that they stick to the topic of the meeting, and I will invite Ms. Rumpel-Garner to carry on, please.
Just on that point of order, Chair, before my time starts, the supplemental estimates do cover a wide variety of expenditures, including the matter that's at hand here. So it is, I believe it's within scope. And I will start
Sorry,
again.
Mr. Chair, then on that point of order, can Ms. Rumpel-Garner specifically point out what section of supplemental estimates she's referring to in her questions around the motion in the House? I'd like to be able to refer to it. So can she point to it?
Thank you, Ms. O'Connell. We do allow quite broad latitude here, but I would invite Ms. Rumpel-Garner if she wishes to respond.
Thank you, Chair. Mr. Stewart, do you intend to comply with both components of the privilege motion passed yesterday as ordered by the House?
Point of order, Mr. Chair. I've asked that the specific Ms. Rumpel-Garner said she was referring to
point of order, Chair. This is debate.
The supplemental estimates, and I asked that she refer to it if she's going to continue in this line of questioning, and I have not received that answer.
Thank you, Ms. O'Connell. I did ask Ms. Rumpel-Garner if you wish to respond to that question. I take it you do not.
Point of order, though, Chair, that is
I'll
debate.
Leave it up. Excuse me, I am speaking. I will leave it up to you to respond or not, and then I will start your clock and carry on with your time. So go ahead as you will.
Thank you, Chair. Mr. Stewart, do you intend to comply with both components of the privilege motion passed before the House of Commons yesterday, as I described earlier in my question line?
Mr. Chair and Honourable Member, I replied to your question when you previously posed it.
You did not actually have a specific response, yes or no?
Well, Mr. Chair and Honourable Member, I answered the question. Thank you.
Mr. Chair, through you, I would argue that Mr. Stewart did not answer the question. Does he intend to comply with both components of the motion passed in the House yesterday, yes or no?
I think the question has been asked and answered. I would ask you to move on, please.
Mr. Stewart, do you intend to deliver documents ordered by the House on June the 2nd to be produced so that they may be deposited with the Law Clerk and Parliamentary Council under the terms of the motion provided in the House of Commons yesterday?
Mr. Chair and Honourable Member, I'm not going to be able to respond about intentions for Monday at this time, but I appreciate the question. I will point out that previously similar motions have created tension that is difficult to manage between the requirements of the Privacy Act and the Security of Information Act.
Did you,
both of which place limits on the ability to provide documents of the nature being requested.
Thank you, Chair. I will point out that the Speaker of the House of Commons ruled on the point that was just made and ruled against that argument in his ruling in the House yesterday. He also pointed out that the National Security and Intelligence Committee of Parliament Act makes clear that despite its composition, the body is not a committee of Parliament. That's why the ruling was made. So going forward, Mr. Stewart, do you believe that your opinion on this matter supersedes an order of Parliament and the ruling of the Speaker of the House of Commons?
Point of order, Mr. Chair. Once again, where's the relevance? And if she'd like to point to the section of the supplemental estimates, I'm still waiting.
Thank you, Ms. O'Connell. I would also request of Ms. Rumpel-Garner that she do let the witness answer as he deems best. So please go ahead.
Yeah, thank you, Chair. I've outlined relevancy already. So I'll ask Mr. Stewart again. Do you believe that your opinion on this matter supersedes an order of Parliament and the ruling of the Speaker of the House of Commons?
Point of order, Mr. Chair.
Ms. O'Connell on a point of order.
Mr. Chair, this isn't the Canada-China committee where the motion originated from. So if the member is not going to stay relevant, I'd ask that you rule that she point out the section she's referring to. This is the Health Committee where we're dealing with supplemental estimates.
Thank you. Chair, on this point of order.
Ms. Rumpel-Garner on the point of order.
Yes, the National Microbiology Lab, as well as the research contained therein, has a significant amount of funding, which is material to these estimates. I could point to numerous other things, but I would ask that you rule on whether or not you think that my line of questions are in order, so that my clock keeps being cut off. I have lost a lot of time. I would ask that you rule on this so that the committee may decide whether to sustain your ruling or not.
Mr. Chair, point of order.
Mr. Chair, I have my hand up.
On the point of order, Mr. Davies, who we haven't heard from yet. Go ahead.
Thank you. I think it's important to clarify what we're doing today. First of all, we are here to discuss the supplementary estimates, and there is historically an incredibly wide berth, not only to ask anything that's in the estimates, but even what's not in the estimates. Second of all, we are also here, these witnesses are here pursuant to the motion of this committee, which is to deal with matters that deal with the government's handling of COVID. Now, the issues at that were before the House originated over concerns raised at the Winnipeg laboratory that was dealing with viruses, and there's a clear connection between that and potential interference or involvement in compromising Canada's COVID research, et cetera. So there's nexuses between this line of questioning and the purpose of which we're here today. What I'm concerned about is Ms. O'Connell has interrupted, I think, 4 times now with the very same point of order, and you have ruled on it repeatedly. And I think there's a certain point where a member who is being repetitive and vexatious and not raising the same point of order repeatedly, given your ruling, it interrupts the flow of questioning. And I think it's a privilege of every member here to have their 6 minutes to do with what they will. And there's no question that these questions are relevant. So I would ask that all members not interrupt each other particularly when their rules, their points of order have been ruled upon, and they've not prevailed on that rule of order. Or point of order, pardon me.
You're on mute, Ron.
Sorry. Thank you, Mr. Davies. Ms. O'Connell, you wish to also speak to this point of order?
Thank you, Mr. Chair. And while I appreciate Mr. Davies' intervention, my ability as a member to raise points of orders, and as any member does, is a privilege point that we all have. And Mr. Chair, to that, if the member mentioned herself that she was referring to a section of the supplemental estimates and then did not cite it. So I appreciate Mr. Davies' comments, but Ms. Rempel-Gardner opened that door and then did not provide the facts or the receipts to back up her comments. And Mr. Chair, my final point on this argument is the fact that Ms. Rempel-Gardner suggested that she has questions about the microbiology lab that would be relevant to the supplemental estimates and spending, which I would agree that that is in bounds. However, her entire questioning to Mr. Stewart has been in relation to a motion in the House, a procedure if he will comply, and she hasn't asked a single question actually on the lab. She has simply asked questions about a procedural motion that came
Chair,
from
this is now debate and we are wasting time.
To do, excuse me, I have the floor. You have not been recognized as from the chair.
On a point of order, Chair, on this point of order?
Please don't interrupt the member. She has a floor on a point of order.
That if Ms. Rempel-Gardner would like to speak about the lab, by all means, go for it. However, I have raised a point of order based on the fact that she is not speaking about that. She is speaking about a procedural matter being dealt with in the House, and I would ask that that be ruled on. That has nothing to do with supplemental estimates, as wide of a scope as the chair permits.
Thank you, Ms. O'Connell. Ms. Rempel-Gardner, did you wish also to respond?
Are you ruling that my line of questions is in order or out of order?
Well, I was going to ask if you wish. I asked if you wanted to respond to the points. However, I am prepared to rule. Well, I agree that We generally give wide latitude asking about estimates. I believe that the microbiology lab is relevant. However, I take Ms. O'Connell's point about the matter, direct line of questioning that you referenced, Ms. Rempel-Garner, is about a House procedure. It's far too peripheral. I would ask that you, I would rule that this line of question is not relevant, and I would ask
challenge your ruling.
Thank you, Ms. Rempel-Garner. So the question is to the committee, shall the decision of the chair be sustained? If you respond yes, then the decision of the chair is sustained. If you respond no, then the matter is determined to be by the committee to be in order. So I will ask the clerk to conduct a vote. Please go ahead, Mr. Clerk.
Ms. O'Connell.
Yes.
Mr. Kellaway.
Yes.
Mr. Pawlowski.
Yes.
Ms. Sidhu.
Yes.
Mr. Van Bynen.
Yes.
Mr. Barlow.
Absolutely no.
Mr. D'Entremont.
No.
Mr. McGuire.
No.
Ms. Rempel-Garner.
No.
Monsieur Lemire.
Non, Monsieur le Président.
Mr. Davies.
No.
So, Mr. Chair, 5 yeas, 6 nays.
Thank you to the committee. So, Ms. Rempel-Garner, you may continue with your
just
line
on a
of
point
questions.
of order, Chair.
Ms. Rempel-Garner, on a point of order.
Thank you, Chair. Can you just let me know what your clock says?
My clock says 4:41, but I think just don't interrupt me, please. But I will give you. I think that we lost at least a minute, so I will give you that it's. We'll call it 4, and so you would have 2 minutes left. Go ahead.
Thank you, Chair. Mr. Stewart, did anyone from the Prime Minister's office, any staff, or anyone from the Minister's office, or any staff, or any other staff advise you on whether or not to comply with the House order made yesterday?
I've had no conversations with anybody in the Prime Minister's office on this topic. And I have not had discussions with my minister's office with respect to the intent to comply on Monday.
Do you believe that your opinion on this matter supersedes the Speaker of the House of Commons?
Mr. Chair and Honourable Member, if I can have the time to respond to this question uninterrupted, I would like to try and take it on since the member has asked it several times. Go ahead.
So yes, I would ask for a yes or no on this.
The witness may answer as he deems appropriate.
Again, Chair, I have a minute, and I've been interrupted many times. So I would like to know, as it is material, if Mr. Stewart believes that his opinion supersedes the will of Parliament on this matter.
You've asked. You should expect to hear the answer. Mr. Stewart can give the answer he feels appropriate. I will make allowances for time, but please go ahead, Mr. Stewart.
Thank you. The way the question's being framed is difficult to respond to. I would invite a different way of responding be considered. I am a career public servant, and as a career public servant, I have to follow the law. There are 2 laws that limit my ability to act. Nothing in the motion has amended the law to date, so it creates a difficult situation. And therefore, it's not about my view of somebody else. It's about the advice I've received about what I'm allowed to do under law. Thank you for the question, Honourable Member.
You do realize, Mr. Stewart, that the law, that Parliament makes laws and also has the ability to determine what documents are produced. So I guess I would just say that you now in a position where you are interpreting the will of Parliament as opposed to Parliament? Is that what you're suggesting to the committee?
Mr. Chair and Honourable Member, that was a very excellent way of structuring what you're asking. In fact, Parliament does make law, and I am required to follow that law. The House of Commons motion does not amend the law, and that's been the challenge in this file. Thank you, Honourable Member.
Ms. Rumpel-Garner, you have 30 seconds left.
Thank you, Mr. Stewart. Mr. Chair, Mr. Stewart, you do realize the Speaker ruled on sections of the law that were applicable to the House order and found a prima facie breach of privilege. So what you just said is out of alignment with what the Speaker of the House of Commons found and what then Parliament ruled upon. So do you find that now you are making pronouncements upon the will of Parliament as opposed to obeying the will of Parliament, as you said in your role as a career public servant?
Mr. Chair and Honourable Member, what I've been trying to say is that the law places obligations on me, and the advice I've received helps me stay within compliance with that law. I don't have opinions of the nature the Minister is ascribing to me regarding the Speaker and his ruling.
Thank you, Ms. Rumpel-Garner. We go now to Ms. O'Connell. Ms. O'Connell, please go ahead.
Thank you, Mr. Chair. Mr. Stewart, let's pick up where you left off. I think that was an excellent point, that the motion doesn't change the law that you are bound by as a public official in this. So in that vein, and the laws in particular around, obviously one set is around privacy and the other is in and around national security. When it comes to national security redactions and that process, I would assume this is not a decision that is made alone by you in particular, but that national security type redactions would be done. Maybe actually the question is, can you, and it doesn't have to be about these specific, but what is that process to considering national security redactions?
Mr. Chair and Honourable Member, you're exactly right. This has been characterized as if it were an opinion of mine. In fact, as I've mentioned, I'm trying to follow the law. And laws also circumscribe what security-related material can be released. And there are legal and also security experts who guide those decisions. As accountable head of the Public Health Agency, I am the person who signs the packet or provides the documents, and hence I find myself in this extraordinary situation in this 27th year of my career. But it's not the exercise of my choice that's putting me here. It's the obligations of my job and making the representations of my organization guided by the advice that were provided by the experts.
Thank you, Mr. Chair. Thank you, Mr. Stewart. And on that, are there any provisions that had you ignored the national security intelligence community or the experts on that part of the redactions? Had you ignored that advice and released documents unredacted in open source format that would prevent, say, like China, Russia, Iran, any other foreign national governments from also accessing those national security information once the information is released essentially publicly? Because the point, Mr. Chair, that I'm making here, and Mr. Stewart, I just wanted, the question to you was about would there be any safety protections once those documents are released. But the Conservatives continue to make this argument that Canadians have to see this information. But what they're failing to also point out is that the law that Mr. Stewart is referring to in terms of national security protections is in place because it's not just about Canadians' eyes seeing this information, but that once it's in an open source or an unsecure fashion, that it's actually bad actors around the world that would love to see Canada's national security and intelligence information. So, Mr. Stewart, had you ignored the law, the advice of national security experts, would there be any protections from stopping other bad actors or governments around the world from accessing Canada's national security and intelligence information? Do you have any powers that would have prevented that broader access once it was in open source format?
Brief intervention before the witness response. Sorry, I was going to ask Dr. Pawlowski to mute, but he's done so. So sorry, I carry on, please.
Okay, thank you, Mr. Chair, and thank you, Honourable Member. You're very right. When it comes to security, there's open source, there's soft sources, and then there's specific intelligence and materials related to things around a level 4 lab are of interest to many parties. I think in the experience I've had over the past several weeks, where we have provided materials, those have been made public immediately by the Commons Committee reviewing the matter. And the cumulative effect of making these materials available, in fact, does in and of itself begin to create security concerns for the intelligence community. The materials that we've not released to date, because of our concerns about security and national security, of course, are classified materials. So the impact you're talking about is even more profound. If I may, we were asked to provide the materials unredacted to a committee where none of the members had security clearances, and they had no ability to handle classified documents, nor even to have secure communications. It was done over the World Wide Web.
And so, sorry, because of my limited time.
Sorry.
Yeah. But I actually am a former member of NSICOP. Mr. Davies is a current member, so we actually understand what is actually required, the difference to receive security clearance, how meetings are handled, the difference between an in-camera parliamentary session versus a secure
Monsieur le Président.
meeting.
Point of order, Mr. Chair.
Pardon me, Ms. O'Connell. Monsieur Lemire, est-ce qu'il y a problème?
Oui.
Mr. Lemire, is there a problem? I have a question for the member. I'd like to know what sections she's referring to in her question when she's talking about the detailed aspect. That's a point of order? Yes. I'd like to hear you on that, please.
Then, Ms. O'Connell, the question has been asked. Do you wish to respond?
Absolutely. Mr. Chair actually ruled that this line of questioning was out of order, and then Mr. Lemire, you voted against it, and so did the majority of the committee members, which then allowed this line of questioning. So the section I'm referring to is your specific vote on the item that overruled the chair's ruling.
I appreciate the answer. You can continue.
Parfait, j'apprécie la réponse.
Thank you for the answer, but I was just curious about it. Thank you.
Yep.
Merci, Monsieur Lemire. Ms. O'Connell, allez-y, s'il vous plaît.
Go ahead, please, Ms. O'Connell.
So, Mr. Stewart, and again, I'm hoping that that doesn't eat up my time as the member, I guess, forgetting the vote that just happened. But Mr. Stewart, so then in relation to that secure process, in reference to the speaker's ruling in addition, at the time, there was a reference to a previous ruling in regard to the Afghanistan war. However, at that time, a secure committee of parliament with security clearance, with the ability to meet in a secure setting, to handle sensitive documents didn't actually exist. So now that that process exists, was this the rationale for then using NSICOP with all these secure protocols to be able to send all documents unredacted to a safe and secure setting with members of parliament from both houses that could handle and understand the national security information in that secure manner?
Mr. Chair and honorable member, it was a committee of parliamentarians who had the necessary classification and ability to handle secret documents. So I provided all documents in an unredacted form to that committee in the hope that that would address the intent. However, obviously, subsequently, it has not addressed the intent. But thank you for the question.
Thank you, Mr. Chair.
Thank you, Ms. O'Connell. On va maintenant à Monsieur Lemire.
We now move to Mr. Lemire. Mr. Lemire, go ahead, please, 6 minutes. Thank you, Mr. Chair. My question will be to Minister Hajdu. Yesterday, we learned that the microbiologist Gary Kobinger, who has developed vaccines against Zika and Ebola and is working on a vaccine against COVID-19, is leaving Quebec to go lead the Galveston National Lab in Texas. The main reason he gave is that money there is not a problem and that there are many projects. He was denied the necessary funding by Ottawa to conduct clinical trials for his vaccine against COVID-19. Even though you've significantly increased funding for research during the pandemic, you haven't maintained that same level, and many researchers don't have enough funding for their research. So what should we do to find a solution? And at question period, you responded to Mario Simard that you're already making big investments, that you're talking to researchers and scientists, and that domestic productivity must increase. Mr. Lamar responded to that in the last hour. He said we need to increase fundamental research by 25% and then 10% over the next 10 years so that Canada can catch up to the other G7 countries. Canada is in second last place currently. Do you feel that you're doing enough currently? What are you waiting for to really increase funding for research and to stop the brain drain? Thank you.
Well, thank you very much. And through the chair to Monsieur Lemire, j'apprécie la value.
I appreciate the value of research as well.
That we continue the path that we've been on in terms of reinvesting in research, science, and evidence in this country after a decade of slashing of scientists, in fact, destroying research and science under the former Harper Conservatives. And that's why we put that at the front and center of our policy in 2015. And thankfully we had, because we were able to build up the research community over the past 4 years prior to COVID-19 hitting. And we were able to mobilize very quickly our Canadian research community to not just research COVID-19, but the many aspects of COVID-19 that would be, I would say, spill-on effects of living through a global pandemic. Perhaps I can turn to Dr. Strong to speak about some of that work through the CIHR. He's here today, and I think the work that the CIHR has been doing with our research community is critically important. Dr. Strong?
Thank you very much, Chair and Minister and Honourable Member for the question. In fact, one of the major investments that this supplementary discussion is about is a clinical trials fund, which will in fact begin to develop again the clinical trials expertise in this country and to support investigators such as Dr. Kobringer in the very early phases of drug trials. For that, it's a $250 million investment over 3 years to establish a pan-Canadian strategy and to assist with the biomanufacturing component. So the investments required are being made as we speak to rebuild, as the Minister has stated. Thank you.
Merci. Je vais
Thank you. I'll continue my questions. You've talked about the importance of long-term funding. There's a strong signal that needs to be sent to researchers, and they're awaiting it. In other terms, since 2017, Quebec has a life sciences strategy. We invest billions in research and development. There are over 600 companies and 32,000 high-quality jobs. July 1st, the PMPRB reform will come into force, even if Mr. Clark told us that the PMPRB never did an impact study on life sciences in Quebec and Canada. But we know that research is at the heart of an ecosystem and that there are many links, and that by weakening the biopharmaceutical link, there will be a weakening of the chain. The Bloc has a plan to modify the basket of reference and delay what is controversial so that there can be a discussion. Nobody wants just one more delay. Do you agree with putting in place that suggestion, Minister?
Well, what I can say through the chair to the member is that we agree that it is important to rebuild our life sciences sector. And that's why my colleague, Minister Champagne, has been working so closely with a number of pharmaceutical companies, including Novavax and many others, to look at how we can strengthen Canada's footprint on biomanufacturing and the life sciences sector. And of course, when we do that, with the many companies that are interested actually in coming to Canada and being part of that sector here with a footprint here, that is an opportunity to strengthen the connection with the research and science in that space as well. So I'm very excited about that work, and I know that the minister would be happy to speak about the ongoing conversations with the pharmaceutical companies and their eagerness to be here in Canada.
Merci.
Thank you, but you're the Minister of Health. I'd like to have a clear answer because July 1st is in 2 weeks. The research ecosystem is fragile. Will you rather delay the PMPRB reform or leave the date as it is now?
Well, thank you. On the subject of the PMPRB, as the member knows, we have already delayed the coming into force a number of times as a result of the stress on the industry, but also on their incredible focus on responding to COVID-19. We continue to have those conversations with all stakeholders, including the pharmaceutical companies, and we'll assess closer to the date how we proceed. And I will just say this, we will continue on our path to lower the cost of drugs in Canada for Canadians as well. This is an important aspect of the PMPRB renewal and adjustments, and we have to stay focused on the fact that Canada pays some of the highest prices for drugs in the world, and that is also critically important to Canada, that we find a way to reduce those costs so that all Canadians can have access to the medications that save lives.
Merci, Monsieur Lemire.
Thank you, Mr. Lemire. Yes, and I'm glad that you're reflecting on that. Thank you, Mr. Lemire.
Merci. We go now to Mr. Davies. Mr. Davies, go ahead, 6 minutes.
Thank you, Mr. Chair. Well, I really want to get to the question about COVID, but I feel like I need to clarify some things with Mr. Stewart and the order of the House. And by the way, I want to say, Mr. Stewart, I very much respect your decades of service and your professionalism. So these questions are not meant to be personal. But the first thing I want to clarify is the very issue before the Speaker concerned the privilege of parliamentarians to receive unredacted documents as a matter of fundamental privilege. Do you not agree with that? That was the nub of the matter of the Speaker's ruling?
Thank you, Mr. Chair and Honourable Member. I answered from the position of my ability to provide those documents, which I believe is material.
I understand. You wrote, in fact, on June 4th, it says the president, I'm quoting from the Speaker's ruling, it says the president of the agency, I take it that was you, wrote to the law clerk and parliamentary counsel informing him that the document sent to him had been redacted because the order of the House did not offer the appropriate guarantees for protecting information related to national security and personal information. And then he added that the agency was cooperating with NSICOP. You made that, the very argument you're making today, sir, you made to the Speaker prior to the Speaker's ruling yesterday. Is that not the case?
Mr. Chair and Honourable Member, I've been consistently making this argument, and I'm making the same argument today.
Yes, and the Speaker rejected that argument. And in taking your argument into account, and this is what he said, and this is what needs to be clarified, because both you and Ms. McConnell, I believe, with great respect, are misrepresenting this issue of national security, because this is what the order of the House says, that the law clerk and the law clerk and parliamentary counsel shall confidentially review the documents with a view to redacting information which, in his opinion, could reasonably be expected to compromise national security or reveal details of an ongoing criminal investigation other than the existence of an investigation. Sir, there is no issue of the documents being redacted for national security. The question is whether you believe that that's your right to do it, or whether you have to comply with the order of the House, as the Speaker has ruled, to have the law clerk do that. Is that not correct?
Mr. Chair and Honourable Member, these are complex areas in which I am advised because I'm not expert, obviously. My understanding is what I'm legally able to do. And nothing in the motions heretofore have made me not legally liable for the choice that I'm being asked to make. I don't know if that responds or if I'm doing is trying to make a determination based on what I'm able to do and be consistent with the law.
Yes, sir, and I'm suggesting to you that, with great respect, that is not up to you to say. This is the second ruling now of the House Commons. Peter Milliken made the same ruling against the Harper government when the House requested the production of unredacted documents. And both times, the Speaker of the House ruled that it's a matter of fundamental privilege of parliamentarians to receive unredacted documents. Sir, it's not up to you to determine whether they're redacted. You have been ordered to produce unredacted documents. And by the way, those documents will be redacted for national security, just not by you, by the law clerk. Now, I want to tell you as well that we've received a letter from the law clerk to this committee. And I want to quote from that. It says, we added that the House and the committees are the appropriate authority to determine whether any reasons for withholding documents should be accepted or not, and that it was for the committee to determine whether it was prepared to accept any proposed measures. We reminded the government officials that the House's and the committee's powers to order the production of records is absolute and unfettered, as it constitutes a constitutional parliamentary privilege that supersedes statutory obligations. Do you disagree with the law clerk when he says that Parliament's privilege supersedes any statutory obligations that you may have?
Mr. Chair and honorable member, the motion of the House and the ruling of the Speaker, do you believe that provides me with immunity from the two pieces of legislation?
So is the issue, you're worried about your immunity as opposed to complying with the order of the House? Is that what this is about, Mr. Stewart? Your own hide?
Mr. Chair and honorable member, as I've been trying to explain, as a public servant, I'm bound by law and I have to follow the law. And so if the advice I'm receiving is actions put me offside the law.
Whose advice are you receiving, sir? Whose advice is giving you that advice?
I'm receiving advice from the normal sources. From
I don't know who the normal sources are, sir. Tell me who the advice is that you're getting to resist this order of the House.
Just if I may rephrase that, I'm getting advice on whether I'm able to release the documents.
I understand.
And,
from who, sir? The question is from who?
Well, it would be the Department of Justice are the people who provide us advice in this area.
I'm going to change my questions here quickly to you, Dr. Tam. How prevalent is the Delta variant in Canada at present?
The Delta variant is now in all provinces and at least one of our territories, in a specific area, one territory. We have just over 2,000 identifications of the Delta variant. But of course, as with all coronavirus cases, we may not know every single case that has occurred in Canada, hence my warning of precaution and the need to get 2 doses of vaccine into as many people as possible.
Thank you, Mr. Davies.
Oh, thank you, Mr. Chair.
That wraps up round 1. We start round 2 now with Mr. D'Entremont. Mr. D'Entremont?
I think Ms. Rempel will go this time.
Okay, Ms. Rempel-Garner, please go ahead. 5 minutes.
Thank you, Chair. Mr. Stewart, in my colleague Mr. Davies' questions, you said that you were referring to the usual sources and providing or getting information regarding whether or not you will be complying with the House order. Who are the usual sources?
As I mentioned, the Department of Justice.
Great. And when my colleague Mr. Davies raised a matter, you suggested that you were looking for immunity. Did you want to expound on what you meant by immunity?
Mr. Chair and honorable member, what I was trying to do was disentangle. I have to abide by the law. And
are you saying that the House order is unlawful?
Mr. Chair and honorable member, the acts of Parliament that I'm following were passed by the House and the rest of Parliament, and they have the full force of law, and I have to act consistent with them.
So, Mr. Stewart, you do realize that an order of Parliament is also lawful, correct?
Mr. Chair and honorable member, you are parliamentarians and know better than I do whether the House of Commons is equivalent to the totality of Parliament. My understanding is an act of law is passed by the Commons as well as the Senate, et cetera, in a more extended process than a motion, but I don't know that area of expertise, and you may know more than I do.
Thank you. Through you, Chair. Mr. Stewart, as Mr. Davies mentioned, the order requires the production of documents to the law clerk for redaction. Do you believe that the law clerk is not sufficiently equipped to redact the documents?
Mr. Chair and honorable member, in order to make a determination about who a classified material can be handed to, normally we would look to the level of protections that they have around the material before we transfer it. That would be my response.
And so you do believe then that the law clerk is not sufficiently able to redact documents via an order of Parliament?
Mr. Chair and honorable member, if you look at the motion and the previous motions, you will see no guarantees in any of the wording that the materials provided will be managed in a way that's consistent with the security required for the level of classification that they have. So I have no information on that front, actually. I can't answer your question.
So it is, Mr. Stewart, it's within your opinion that the Speaker was wrong in ruling a prima facie case of privilege?
Mr. Speaker and Honourable Member, you've asked me several times for an opinion about the Speaker's opinion. This is not an area where I'm expert, and I have tried to avoid even appearing to have such an opinion. So I would say, as I have previously, I don't have an opinion about that.
Thank you, Chair. I will now pass the floor over to my colleague, Mr. D'Entremont.
Thanks. Let's go back to some of the questions that Mr. Lemire was actually asking to the Minister about the PNPRB. So from what I understand from your answers, that the regulation changes will happen on July 1st. Is that correct?
We're still reviewing the PMPRB. As you know, it's been delayed twice because of the obviously state of a pandemic and the incredible focus of the pharmaceutical industry on responding to the pandemic. And we're assessing right now the next steps on the PMPRB.
How are those assessments taking place? Is there a little consultation going on? People writing in? I mean, how are you doing that?
A variety of different ways, including speaking with the industry and other stakeholders.
Okay. Has it been considered within it, some of those recommendations that have been provided by patient groups? Mr. Lemire just spoke to a number of those requests, changing the basket of countries, particularly taking out the US, taking out Switzerland, I believe was the two that were creating a challenge. Trying to find a way to implement the regulations in a more sort of a longer period, and then trying to find a way to actually have consultations, true consultation between PNPRB and the patient groups.
Well, actually, those consultations have been ongoing and regular. In fact, I've met with a number of patient groups myself, as well as a number of other stakeholders, including industry stakeholders and Innovation Medicines Canada. So those are ongoing conversations, I would say, that my office and I have on a regular basis.
In those discussions with the patient groups, did you apologize a little bit for the work that PNPRB did, especially when it came to certain patient groups on trying to find a way to make them seem being bought out by the pharmaceutical companies?
The conversations I've had with the patient groups have been extremely respectful from both sides. I would say that the patient groups have understood that the government, at the end of the day, is trying to make the very expensive medications, in some cases for their particular illness group, more affordable for their families. For example, we know that Trikafta has just received approval here in Canada. Now the real challenge is that the affordability of that drug. And so patient groups fully understand that the government is trying to do a number of things. One, obviously reduce costs of drugs, especially those high cost drugs. They appreciate the work that we're doing as well on the rare disease strategy, because of course, many of those patient groups are not just advocating for access, they're advocating for affordability. And so they understand that this is a complex landscape and that we will continue to meet with them on a regular basis. And we have never shied away from meeting with any patient group.
Thank you, Mr. D'Entremont. We go now to Ms. Sidhu. Ms. Sidhu, go ahead, please, 5 minutes.
Thank you, Chair. Thank you, Minister, for joining us today with your officials. Thank you all the hard work and you and your team are doing. In my line of questioning, I tend to focus on matter that matters to Canadians. Minister, as we speak, a family of long-term care residents are protesting the conditions of their parents and grandparents in long-term care in Ontario, and this is happening right now in my riding. We can never see a repeat of the tragedies that occurred in these homes over the last year, and we have been there for them in Ontario. What work is being done to address these issues in the short term, and what is being done to ensure these tragedies will never happen again?
Such an important point from the member, and through the chair, I'd just like to thank the member for her very hard work in her riding with long-term care homes and their residents. And she's absolutely right. This has been a national tragedy all across the country, in some provinces far worse than others. We know in Ontario and Quebec, for example, those scathing military reports of the conditions of long-term care homes in those provinces horrified all Canadians, and much more has to be done. And that's why the Prime Minister made that commitment and stepped up to provide support to provinces and territories now and into the future to strengthen protections for long-term care. So for example, the fall economic statement provides $500 million from the Safe Long-Term Care Fund to through the SUP estimates A to strengthen infection prevention control measures and to spend that money on the ways that they can secure a stable workforce so that people are not left alone in undeniably terrible conditions for very long. We will also say that I'll also say that this builds on the $740 million that was already provided through the Safe Restart Agreement. Budget 2021 also has a lot of money dedicated, $3 billion dedicated to working with provinces and territories on measures that will strengthen protection for people in long-term care home. And of course, we're working towards those national standards and how we can actually ensure not only do we have national standards, but that they are enforced so that no matter where you live in this province or territory, if you're a resident in a long-term care home, either an elderly person, a person with a disability, or other people, that you have the security that you can live there in dignity and safety. Thank you for your question.
Thank you, Minister. Research has been critical in the fight against COVID-19, and Canadians can be proud of the work our scientists have done in advancing our understanding of the disease impacts, treatment, emerging testing technologies, and vaccine. Minister, or perhaps Dr. Strong, what research do you expect will be needed as we shift to a vaccinated world?
Thank you very much. And through the chair, MP Sidhu is absolutely right. We have supported over 400 COVID-19 research projects in some of the very key areas you've mentioned. So I'll turn to Dr. Strong to speak a little bit about maybe highlighting some of that work.
Thank you very much, Chair and Honourable Member, as well as Minister, for the question. In looking forward into the next steps of research that are going to need to be done, it will build on these investments that the Minister was referring to, and in particular looking at the long COVID consequences, both in terms of the type of biology that underlies this syndrome, which we know very little about at the moment, but also the devastating effects on individuals who have had this, irrespective of the degree of disease that they suffered. So we need to understand that, so there will be investments along those lines. We understand the major impacts on mental health as well, so investments are already being made, and indeed in our rapid response programs, we've asked specifically for researchers to focus in these areas to assist in their care and in helping develop the next steps as we move forward. Thank you.
Thank you, Dr. Strong. I think mental health, thank you for mentioning that mental health is impacted very much. Minister, Brampton peaked at more than 1,000 new cases in a day during the third wave, but today it was 50. This is thanks to the vaccination effort made possible by the increase in vaccine deliveries and the work of healthcare workers and volunteers on the ground they are doing. Just last week, I was at the CA Center in Brampton, which is one of the largest and most active vaccine clinics in the country, administering over 5,700 doses a day. Minister, are you optimistic that the worst of the pandemic is behind us and Canadians will be able to return to the normal fairly soon?
Minister, may I answer?
Sorry, I was on mute. Thank you very much, Mr. Chair, and to MP Sidhu. Certainly, it's looking a lot better for people in Brampton and across the country. The vaccines are making a big difference, and so are the public health measures that the provinces and territories have imposed. Some of them, albeit later than we would have liked, but nonetheless, they're strong, and the cases are coming down with those combination of factors. In fact, over 35.3 million vaccines have been delivered to provinces and territories today. And as you know, the Prime Minister and Minister Anand announced today that we'll be getting 11 million more Moderna doses earlier than we thought, which means that more early second doses will be administered across the country. And so this gives us a much better outlook in terms of moving into the late summer and fall and what we might expect in fall of 2021. You know, one thing that's really hurt my heart, and maybe yours as well, is the challenge that many children have had, in particular in provinces that have had schools closed for so long. In fact, in Ontario, it's the jurisdiction where schools have been closed the longest across the country. And many researchers are now saying that there will be a long effect of students being out of school and not being able to study. And so this is my hope, and I'm sure yours as well, that in the fall, we'll see students return to classrooms, get the education that they need and deserve in a way that helps foster their social development and keeps families being able to do the many things that they do as a result of our education system. Thank you.
Thank you, Ms. Sadu. We go now to Mr. McGuire, I believe. Mr. McGuire, go ahead, please, 5 minutes.
Mr. Chair, I have a couple of questions, and I may have another colleague who wishes to come into this as well. But last fall, I'm just wanting to go to the estimates here on the budgets. Last fall, there was an announcement of $1 billion for funding in the long-term care facilities that were but there were no details in the recent budget. Your department is seeking approval of $500 million in supplemental estimates A. So if the original press release in that it said funding will be contingent on detailed spending plan, I don't believe your department has shared that detailed spending plan for the program with this committee. And so I want to ask if it's publicly available now.
Well, through the chair, Mr. Chair, and to the member, there was no shortage of things to spend money on in long-term care, especially in the early surge days where provinces and territories were unequipped with personal protective equipment, with infectious disease training, staffing shortages. In fact, we spent millions and millions of dollars sending in the Red Cross to help offset
Minister, I've got other questions here to ask, Mr. Chair. I've got a short amount of time. Can you just table the list?
Through the chair, I'll turn to my officials for that answer.
No, I'm asking you if you can just table the list. You've got lots of spending. You said there was be $1 billion. You've put up $500 million, so that's about half of it. Surely there's a list, and I just wondered.
I'm sure we can get you a breakdown of how that money was spent.
Okay, thank you. You could table that. It'd be great. Before determining that $1 billion figure, did your department provide you with any inventory of which specific long-term care facilities in Canada are in urgent need of infrastructure improvements?
Well, thank you. And through the chair, we also stepped up in the area of infrastructure. And I want to thank my colleague, Minister McKenna, for acting so quickly on her infrastructure fund that deals with exactly that, the emergency infrastructure repair that was needed in provinces and territories to help them deliver on their responsibility to care for seniors in their care. You know, the federal government decided early on that we would not squabble with provinces and territories about who paid for what, and we stepped up in an unprecedented way. I'm sure the member realizes that, in fact, we spent billions and billions of dollars helping provinces and territories deliver on their requirements and on their responsibilities, and we'll continue to do that because we've said to Canadians, MP McGuire through the chair, that we'll have their back for as long as it takes with whatever it takes.
Yeah, there's a lot of infrastructure improvements. I'm sure it's part of the $500 million now. Before determining this $1 billion figure again, did your department provide you with any specific numbers on the many of the current staff shortages there are in personal care homes across Canada and what that shortfall might look like in the years to come?
Mr. Chair, this is an area that we have been working with provinces and territories on as well. And in fact, we gave a significant wage top up as part of the challenge.
Can you just table the shortfall?
Mr. Chair, I'd like to turn
Point of order.
Ms. O'Connell, on a point of order, go ahead.
Mr. Chair, the standing orders state that a member can ask their question and the witness has the time, generally equivalent time to respond. Mr. McGuire isn't asking if these things can just be tabled in his question, so he needs to provide time for the minister or any witness to actually be able to answer.
Mr. Chair, on the point of order.
On the point of order, go ahead.
Yeah, just to that. I mean, we saw in the previous question that the minister was going to get the staff to answer that, but it's a tabling. It's a document that the government has put out, and so all I'm asking for is that this is pretty much a shortfall that's somewhat well known across the country, and so I'm assuming that, and I know that they've been working on it, so I'm assuming that she could just table that information for us because I have more questions, and I only have a limited time. Thank you.
Point of order, Mr. Chair.
Ms. O'Connell, on the same point of order.
If Mr. McGuire just wants the minister to table things, then I would suggest he ask her that in those questions. But if he's going to ask the question, then she needs the opportunity to answer. If his question is just table it, then he can just say that, but that's not what his questions were. So I don't mean to be a stickler, but if he's going to ask the question, he needs to hear the answer.
Thank you, Ms. O'Connell. And I would actually agree that if the witness should be able to answer the question asked, and I certainly understand Mr. McGuire's perspective. He'd like to have these tabled, but Mr. McGuire, go ahead, please. You have 2 minutes left.
Yeah, thanks, Mr. Chair. The announcement, in that announcement that the government made, it also said that the funding will be allocated on a per capita basis. However, we know that there's urgent need to improve and expand these personal care homes in small and rural communities. So can the minister just tell me quickly whether or not this funding will be allocated directly to the provinces, or will each project need the government signature, perhaps her signature, before any federal funding is transferred?
Mr. Speaker, one of the things that I heard most profoundly from Canadians is they actually want results for the money that is spent in the space of long-term care. In fact, what they don't want are transfers to provinces and territories that don't result in tangible improvements in the lives of the long-term care residents. We're negotiating with provinces and territories right now on what the next tranche of money will look like and how best to deliver on that commitment that we all made together, all provinces and territories and the federal government, to protect the people living in long-term care. I'll continue to deliver on that promise on this side.
Yeah, I know time is of the essence, Mr. Chair, and so I believe that with that, many of the personal care homes need to be modernized. And so will there be a requirement for the provinces to access this program within a certain timeline?
Mr. Chair, we're still working with the provinces and territories on what the new money will look like and how we can best achieve the goals to protect the seniors and the other people requiring care that live in those homes. And I'll continue to negotiate with the best interests of Canadians in mind.
I'll just make an observation to finish my time, Mr. Chair, that with $1 billion ask, or $1 billion and a $500 million commitment, it seems that there is less than a commitment to make sure that we're meeting the obligations that the government identified to start with. Thank you.
Thank you, Mr. McGuire. We go now to Mr. Kellaway. Mr. Kellaway, please go ahead, 5 minutes.
Thank you, Mr. Chair. My question today will be for Minister Hajdu. Last week, the testimony from the folks who were here on behalf of Dan's Legacy in Vancouver was really compelling and actually hit quite close to home for me. And it's something I think all members and all Canadians would agree is relevant to Canadians coast to coast to coast. We know that the opioid crisis is one of the most significant public health crises in Canada. And my heart, I know our hearts go to those who've lost a loved one or who are struggling with addiction right now. So Mr. Chair, through you to the minister, some context. My riding covers a large portion of rural Cape Breton, as well as small rural communities in mainland Nova Scotia. It's the geographic area of the province that makes up what the Nova Scotia Health Authority refers to as the Eastern Zone. So put this in perspective. In Nova Scotia, there are 1,638 individuals in active opioid recovery. And the majority of those, about 830, are in our zone, my zone, the Eastern Zone. I want to thank David Soller, pastor for the Lighthouse Church and a youth director of Undercurrent Youth Center, for all of his work on the ground and providing those stats to me. And colleagues, unlike previous governments, I'm proud that our government is treating the opioid crisis as a public health issue, not a criminal one. And as you know, both the province of British Columbia, and the city of Vancouver are both working with Health Canada to explore how those with substance use disorders can better access treatment. It's quite frankly an approach to this crisis that I've been following very closely to see how it could be applied to the communities I represent. So 2 questions through you, Chair, to the minister. What are we hearing from organizations on the ground? And do you think that this is the right approach? Why or why not? And the second question is, and this is equally important, in this type of collaboration between all levels of government, do you think this is something that we can expand beyond the current work Health Canada is doing with the city of Vancouver? Thank you.
Well, thank you very much. And first of all, my heart breaks for families who are struggling with substance use and problematic substance use, including opioid use. And I do have to say that the stigma of dealing with substance use, problematic substance use, is partly what keeps people away from effective treatment and harm reduction services. And I'll just tell you, on a personal note, this is a multi-generational challenge in my family. And it is partly why I'm so passionate about this. I've seen too many lives personally that have been destroyed and damaged as a result of problematic substance use. And I think if we look in our souls, we can all say that we know someone we love that struggles with problematic substance use, or maybe we have ourselves. And that's why I think these honest, open conversations are so important, because the more we can talk about it, the more they can talk about it, and the more people can feel safe in reaching out. And that's the point, I think, behind the conversation around safe supply and harm reduction and decriminalization. It really isn't about encouraging drug use, which some conservative opponents might say, and have said, in fact, in the harmful policy that under the Harper legacy for a decade, but rather it's about meeting people where they're at and offering supports and services in a compassionate way that reduces the risk of dying. I used to have a colleague that says, no one can get treatment if they're dead. We have to save lives so that people have an opportunity to get better. And that's exactly the focus of this Liberal government. We will work with communities on tools that they feel appropriate, including safe supply, including harm reduction, including safe consumption sites, including making sure that community groups on the ground who are doing that hard work every day with families have what they need to keep doing that work. And finally, let me just say, if you have not heard of the group Moms Stop the Harm, please go and visit that website. Listen to some of those moms. They will tell you heartbreaking stories of their young people who have died of opioid overdose, and they are begging governments to be nonpartisan in this approach and work together to get the job done to save lives.
Thank you, Minister. And it speaks to the importance of looking for creative solutions with all levels of government, but in particular, those community groups like Undercurrent Youth Center in Glace Bay, where I represent, one of the areas that I represent, to see the work that's being done on the ground, but also seeing what the work that's being done on the ground in Vancouver and how they're working with the federal government through Health Canada. It's something that I know is absolutely essential to Canadians, and in particular, people in rural Canada. Oftentimes, and I know we hear it is a tremendous problem in urban Canada, but it's also a tremendous problem, perhaps not as seen as much, but it is still there. So I really thank you for that answer. How much time do I have left, Mr. Chair? If you're there. I'll say 3 minutes.
Sorry, I think I was muted there. Okay. What I said was nice, though. I said you're officially out of time, but okay. If you can come to a question quickly, the minister may answer.
Just around, we talked about innovations just briefly in the latter part of that answer and question. Just looking at virtual care services that have emerged from COVID, the ability to respond innovatively. Do you think that's something that the government should invest in more, especially in particular with rural Canada? I've seen some pretty substantial and positive changes as a result of virtual care, and I know it's a provincial responsibility, but I also know we have a role too. Just your thoughts on that.
Well, thank you very much to the member for that question as well. And it is one of the silver linings, and there aren't many, of COVID-19, although maybe we'll find more over the next decades. But right now, I'll say it is a silver lining of the pandemic that virtual care was able to arise so quickly, and that provinces and territories quickly sprung into action to create, for example, billing codes to be able to properly compensate healthcare practitioners for providing care online or in virtual ways. And I think that I also come from a semi-rural community, and I would say that, the work that we've been doing with provinces and territories to strengthen access to virtual care is really critical. We've provided $240 million in funding, including $72 million through SUP Estimates A, and this is about building up the capacity to deliver virtual healthcare services in a way that protects people's privacy, protects the data, and ensures that people get that quality care. I know that this is not going to replace in-person care, but it certainly can augment in-person care, in particular for people who have a hard time getting access to in-person care. Thank you, MP Kellaway, and through the chair.
Thank you, Mr. Galloway. We go now, I believe, that Mr. Barlow is taking Mr. Lemire's slot. Is that correct?
No.
On mute. Sorry.
Non, je
Thanks
peux
for...
prendre mon tour de parole, Monsieur le Président?
No.
Oh, sorry.
Okay.
Je suis quelqu'un de généreux, mais peut-être.
I'm generous, but maybe not quite that generous.
Okay, so I'm not clear who's next. I have on my list would be normally Mr. Lemire. Is that
Je vais y
Mr.
aller, Monsieur le
Lemire?
Président.
Yes, I'll go ahead, Mr. Chair. Mr. Lemire, go ahead, please. 2.5 minutes. Thank you, Mr. Chair. First, I'd like to respond to what the minister said. When you ask the question, to all Quebecers, nobody wants conditional transfers from Ottawa. What we want are unconditional transfers, especially for health. It was unanimously voted by the National Assembly to increase healthcare transfers without condition to 35%. But, Minister, you say on Health Canada's website that with the 2 interim orders, you've loosened the rules for COVID vaccines to make Canada attractive and to have more therapeutic options for Canadians. But with the PMPRB reform, you'll be doing the opposite. You'll be tightening the rules without having listened to stakeholders, and there's uncertainty, and the complexity of these rules will have an impact on the launch of new medications in Canada and clinical trials. Are you aware of that major contradiction?
Well, thank you. And through the chair, given that I can't see the part of the Health Canada website, I'll take a guess in that you're talking about the accelerated regulatory ability of Health Canada to review vaccines coming in for approval. And in fact, that's separate from the PMPRB. That is actually about making sure that we have the capacity to rapidly assess treatments or drugs that are being used for COVID-19 in a way that does not delay them through an approval process. The PMPRB, as you know, is about pricing of drugs, and it is a different process.
Yes, but there's a contradiction in there. And I'd like to talk about the importance of delaying the implementation to ensure there's no contradiction. We agree on the basket of countries because even the industry is ready to make that concession to lower prices. And Minister, I'd like to hear what you have to say. I'd like to see you show leadership and perhaps chair a table of discussion for the rest of the implementation for the PMPRB with industry representatives, patient groups, and scientists and life science representatives, and from other organizations, those from the PMPRB, biotechs, and pharmaceutical companies. Would you be willing to take on that leadership role to ensure a long-term vision for our pharmaceutical industry?
Well, respectfully through the chair, that's exactly what this Liberal government has done since the beginning of our term in government, is actually take on this challenge of trying to work with the pharmaceutical companies, of patient groups, and indeed with the provinces and territories to look at how we reduce costs of medication for Canadians in this country. This is an important piece, and I absolutely agree with the member that COVID-19 has made this more challenging, given the landscape of COVID-19 and the contribution that pharmaceutical companies are making to beating back COVID-19. We'll continue. We haven't stopped, actually, talking to all of the stakeholders that the member opposite has referred to, and we'll continue that hard work so that we can determine the future of the industry here in Canada, and also how we move forward with both of those goals to make sure that Canadians have the access to the best and most cutting edge drugs in the world, but also that Canadians can afford those drugs. That is, both of those principles are important.
Merci, Monsieur Lemire.
Thank you, Mr. Lemire.
Go now to Mr. Davies. Mr. Davies, go ahead, please. 2.5 minutes.
Thank you. Minister Haidu, you mentioned Mum Stop the Harm. Mum Stop the Harm very clearly believes that and state that it's the criminalization of drugs that contributes to many of the harms of drug use. Do you agree with them?
I have been very clear throughout my entire career that decriminalization may be one aspect of helping people who use substances, but that it needs to be a multi, there needs to be many components to actually reducing harm related to substance use. In fact, I was the author of the Thunder Bay Drug Strategy, which has 5 pillars of action. and none of them individually will save lives. We need multiple actions on multiple fronts, which is why this government has invested so much money in substance use and harm reduction to restore some aspects that were severely damaged under the previous government.
Well, Minister Hajdu, there's not a person in the country, including Mum Stop the Harm, who ever asserts that decriminalization by itself will fix the problem. Mum Stop the Harm also points out that criminalization forces drug users to get their drugs from the street supplied by criminals. And with the poison toxic street supply, this leads to avoidable overdose deaths. Do you agree with them?
That's why, through the chair, we have been so aggressive on funding safe supply projects across this country, because of course it's not just about decriminalization, it is also about making sure that people have access to a safe supply. And it's been a privilege to be able to work on these issues with multiple stakeholders. Unfortunately, some provinces and territories are not taking up the tools that I've offered them repeatedly in terms of making safe supply more easily accessible to people who use substances. And then finally, I'll say, I find it ironic actually that this member is talking about decriminalization. In 2015, in fact, when I ran in the federal election, the Liberal Party was the only party talking about the legalization of cannabis. And in fact, that member's party was not brave enough to talk about that. And so I will just say this, we are a party that believes in pragmatic drug policy that will save lives. We believe we need to work with communities, and that's exactly what we're doing.
Yet you, Minister, and the Prime Minister have explicitly ruled out decriminalization of drugs. Tell me why.
Well, in fact, no, what I have said repeatedly in press conferences is that two things. One, that communities can determine the tools they need, and that my job as a Minister of Health federally is to help enable them to get those access to those tools. And secondly, and the Prime Minister has said this as well, there is no silver bullet to solving the problem with opioids or any problematic substance use. This is a comprehensive approach that includes many other areas that we're investing in. By the way, reducing poverty through things like the Canada Child Benefit and our investments in affordable housing and the supports for racialized and stigmatized members of our community. So those are the folks.
But a comprehensive approach that doesn't include decriminalization is not a comprehensive approach.
Well, I would argue that we have done, actually, we have legalized cannabis in this country. I would say that.
I'm talking about other drugs, opioids.
I would also say.
Thank you, Mr. Davies. That brings round 2 of our questions to a close, and we start round 3 now. So we go with the Conservatives, and I'm not exactly sure who's going to take that. Mr. Barlow? Go ahead, Mr. Barlow. 5 minutes, please.
Thank you very much, Mr. Chair. And Minister, the expert panel on COVID-19 testing and screening provided very clear evidence that quarantine hotels have been a failure and recommended they be canceled immediately and replaced with a comprehensive home quarantine. When will the hotel quarantine program be scrapped?
Again, I think I've answered this question a number of times in the House, but I'm glad that I have an opportunity to speak to it a little bit more robustly. In fact, what we have done is follow the advice of scientists and researchers on how best to reduce the importation of COVID-19. And every step of the way, we have added measures to protect Canadians against COVID-19. We'll be very careful and cautious in removing some of those measures. Of course, we thank the expert panel for their report, and it provides a very useful roadmap, but we will not put the hard sacrifice of Canadians at risk. This has been an extraordinary time of sacrifice for Canadians. Canadians expect us to proceed in a way that does not put their progress at risk.
Thank you very much. But the science and data from that expert panel says that it's inefficient and ineffective and should be shut down immediately. And yet you are even the co-chair of that panel, Sue Page, said that we don't have any evidence that established the efficacy of the three-day hotel quarantine program. Do you agree with that panel's evidence on the data of this statement?
What I'll say is, first of all, I thank Sue Page and the other members on that committee for their ongoing reflections on the role of border measures.
Do you agree with the statement, yes or no, that there's no proof that hotel quarantines show any efficacy?
I will also say that whatever we do next on the border will be guided through the lens of science and evidence, and we will not put the sacrifices that Canadians have made at risk.
Well, that's interesting, because the science and evidence of that expert panel says it has no effectiveness whatsoever. So you can't say we're going to live by some of the evidence as long as it fits with our political view and ignore that which doesn't. But you've said in the past in the media that families will not be split coming back into Canada. Will children under the age of 12 who are ineligible to be vaccinated right now, will they be exempt from hotel quarantines?
I stand by my word through the chair that we will not split families up when they return to Canada.
So in that vein, does the entire family have to go to a hotel quarantine, or will they be allowed to quarantine safely at home?
We will be releasing measures for the next phase of reopening the border in the very near future, and I encourage the member to stay tuned.
But you're saying you won't split families up, so will they all have to go to a hotel quarantine or not? Yes or no?
Families will not be separated during the process of returning to Canada.
Okay, so we've already seen that you've spent $225 million on the hotel quarantine, and now you're asking for an additional $1 billion for isolation sites and border measures. How much of that $1 billion will be spent on hotel quarantines?
To that, I'll turn to my officials, but before I do, I'll just say that the isolation sites, in fact, are around the country, and they have been at the request of communities who are providing isolation for families or other residents that don't have the ability to quarantine. And in fact, we stepped into this space willingly because we knew we would be able to reduce cases of COVID.
But Mr. Chair, she's not answering the question I asked her. She's not answering the minister is not answering the questions I asked her. I asked her very simply, how much of the $1 billion is going to be spent on designated hotel quarantine sites that even our Prime Minister isn't willing to use?
Thank you, Mr. Barlow. It is up to the minister to respond to these questions as she deems appropriate, or to ask her officials to do so on her behalf. It is up to the minister. So, Minister, if you wish to respond, go ahead.
Well, again, I will just say that the isolation sites, as I was trying to explain, have served a critical importance for communities and have been at the request of communities. In fact, it's been an important component of communities to be able to isolate close contacts and positive cases of COVID away from other family members so that they can reduce the spread of COVID. And we'll continue to be there, Mr. Speaker, whether it's at the border when people don't have appropriate quarantine plans, or whether it's in communities where people don't have the ability to quarantine safely away from their families to protect the spread of COVID-19.
Can you please answer the question I asked? How much of the new $1 billion that you've requested in the supplementary estimates is designated for hotel quarantine sites?
Okay, well, I will turn to my officials to speak to the specifics of the budget.
You could have done that 30 seconds ago.
Mr. Chair, Honourable Member, thank you for the question. We don't fund government-approved accommodations. The travellers pay for those directly themselves.
Well, then, to Mr. Stewart, what was the $225 million in the previous budget that was designated for designated hotel quarantine sites? What was that $225 million for?
This is a term, Mr. Chair and Honourable Member, thank you for the question. There's terminology, maybe to declutter. There's the government-approved accommodations, the PHAC hotels, and then there are designated quarantine facilities, which are infection control containment units. And so if you wish me to explain what's in the envelope of money, I can do that, but it's not for government-approved accommodations.
Just to save time, and I've seen my red card, if you can just submit that to the committee, that would be beneficial. Thanks, Mr. Stewart.
Okay, thank you, sir.
Thank you, Mr. Barlow. We go now to Mr. Van Bynen. Mr. Van Bynen, go ahead, please.
Thank you, Mr. Chair, and thank you also to the Minister and officials for joining us once again today. I know this is a very busy time, and you all carry a heavy burden of care for our nation. So I truly appreciate the opportunity to welcome you and to hear from you directly. And certainly I won't downgrade responses to a simple yes or no. I think the issues that you're dealing with are complex and deserve the opportunity to have a fulsome response. Minister, I've been seeing that the federal government has been stepping up consistently throughout the pandemic in a number of ways, but perhaps one of the most significant ways is through the nurses, the Canadian Red Cross workers, and other public health support staff that have been sent to all corners of the country. Now, what kinds of human resources support has PHAC been able to provide to the provinces and territories, and where do you think the support has been most impactful?
Well, thank you very much, and thanks for the opportunity to the Member of Parliament for, through the chair to highlight the Team Canada approach that we decided on earlier. And I think I started to speak about that too in response to another member's question. We really felt at the beginning of this pandemic that, although we have jurisdictional roles and responsibilities, that Canadians needed us to, as a federal government, step up and help. And Health Human Resources has been one of those aspects that provinces and territories have called on us to do so. Early on in the pandemic, we created a rapid response program that could move vital resources like nurses, doctors, and other critical public health workers, epidemiologists, to provinces and territories when they needed extra help. And so, for example, earlier this year, we helped coordinate the deployment of doctors and nurses from Newfoundland and Labrador who volunteered in Ontario to help on the third wave. And I'll just turn to Dr. Tam to speak a few more words about other resources we provided to provinces and territories.
Thank you for that question, and Mr. Chair. A lot of the times we provide epidemiologic support, so technical epidemiologists, laboratory support. We also provide infection prevention control specialists, be it outbreaks in correctional facilities or in remote communities, or on the request of provinces and territories. And we also have leveraged the Canadian Red Cross. Through them, many communities, be it testing sites, sometimes vaccination sites, have had support. And of course, the support of for contact tracers, and in conjunction with Statistics Canada, and of course, our Canadian Armed Forces colleagues. And together, that team has been brought together. And in fact, even staff from the agency who's already very, very busy, if there is a need, they've been stepping up on top of what they're doing to help others as well.
Well, thank you. In my community of Newmarket, Aurora, our local hospital accommodates over 1.2 million people. And at the very beginning of this outbreak, I know that there was a lot of stress in terms of finding the resources that they need. And I was certainly happy to see that the government stepped up and provided what was required. We've also been talking about mental health and the impacts of the pandemics on Canadians' health throughout the past year, and the role of the federal government has been able to play in getting Canadians free, accessible mental health resources. Now, I know that Budget 2021 extends the further funding for the Wellness Together, also in Budget 2021-2022 year, and in the Supplementary Estimates A for additional funding for the Kids Help Phone. Now, why do you think it's important to keep these mental health supports available to Canadians, even as we return to the new normal life?
Well, thank you very much for the question. And I will say, I had an opportunity to meet with the volunteers of the Kids Help Phone just this week. And what an enormous piece of work they're doing for Canadians, responding to calls from people, often young people, but actually people of every age across the country. And we knew early on that we needed to support that work. And Wellness Together also grew out of a sense that the pandemic was going to create such change in Canadians' lives that it would exacerbate mental health conditions, that it would put people into stress at all hours of the day or night. And we wanted to make sure that no matter what a Canadian's circumstance, no matter what a person's circumstance in this country, they would have access to that service. And so we will be extending these services for another year because we know that A, we're not out of this yet, and B, as people return to their lives, many things have changed. People have suffered tremendously. There's been enormous sacrifice, some that we know, some that we don't know. People's routines have been disrupted, their relationships have been disrupted, their work settings have been disrupted. And we know that Canadians will continue to need support for some time to come. And so this is our contribution to ensuring Canadians have that help when they need it through emergency helplines, but also through the Wellness Together portal that helps connect people to the help they need when they need it in the language that they need it in.
Thank you. Thank you, Mr. Van Bynen. We go now, I think, to Mr. Davies. Mr. Davies, I believe it's up to you now, 5 minutes.
Thank you, Mr. Chair. Mr. Stewart, would you table the legal advice that you received from the Department of Justice advising you on complying with the parliamentary order with this committee?
Mr. Chair and honorable member, we do not table the legal advice that we get.
Mr. Stewart, you are probably aware that the privilege of that advice is yours and you may waive it. Will you waive that privilege and table that legal advice with this committee?
Mr. Chair and honorable member, no, I will not waive the privilege.
I'll tell you why I think that's important is I think all Canadians would like to know whether the Department of Justice is advising public servants not to comply with orders of the House of Commons. Do you agree that would be a concern of Canadians?
Mr. Chair and honorable member, I'm actually in no position to know the will of Canadians on this matter, so I won't conjecture. Thank you.
Okay, before I leave this, I just want to be clear. So we've had two orders of the House, one by Mr. Milliken, one now by the current Speaker of the House, that deals squarely with an order of the House that orders the government to produce unredacted documents to Parliament, and has and both of those rulings have stipulated that it is as fundamental to Parliament's operations and a foundational privilege and right of holding government accountable that no government can lawfully refuse to produce unredacted documents to the House of Commons when so ordered. Do you dispute that, Mr. Stewart?
Mr. Chair and honorable member, I've been saying in the course of this proceeding that I'm governed by a desire to stay within the law. I don't have opinions of the nature you're asking after.
Well, second of all, the next proposition I'd put to you is the arguments that to resist producing those documents out of concern for national security were squarely presented and heard by the current Speaker, who ruled that notwithstanding that argument, he still was ordering you to produce those documents. Do you acknowledge that?
Mr. Chair and honorable member, to my understanding, nothing that has occurred changes my legal obligation under the Security of Information Act, which is, as you know, including sanctions, including in the criminal code. There's very strict limits and sanctions for the behavior that is being indicated that I should follow.
Mm-hmm. And you are aware that the Parliamentary Law Council has written to this committee, and it's been stated in the Speaker's ruling that no statute of Canada supersedes the supremacy of Parliament to order production of documents when that's ordered. Are you aware of that?
Mr. Chair and honorable member, as I mentioned earlier, I'm not advised or aware that the motions relieve me from my legal obligations.
And finally, you are aware that the terms of the order specifically state that the documents will be redacted by Parliamentary Council for national security reasons, among other things, before they would be provided to the Canada-China Committee. You're aware of that, aren't you, sir?
Mr. Chair and honorable member, as I mentioned last time we touched on this topic, nothing to date has been provided that would indicate the normal security requirements related to classified documents are in fact going to be upheld.
Well, with great respect, sir, yes, indeed, something has, and that is the ruling of the Speaker squarely says everything that I just said to you. Minister Hajdu, I'd like to ask you, when can cystic fibrosis patients in this country get access to Trikafta that they so desperately need? When will that happen?
Well, thanks, MT Davis. And in fact, I will turn to Stephen Lucas, but Trikafta was just approved, I think, either yesterday or today. Dr. Lucas, can you just confirm that?
No, I understand it was approved. That's why I asked the question, ministers. Yes. I know it was approved. So when's it going to get in the hands of patients in this country?
Thank you, Mr. Chair. In response, following the Health Canada approval, provinces and territories need to make listing decisions. The Canadian CADA, the group doing health technology assessment, and INES in Quebec are providing their advice to provinces in the coming weeks. And following that, provinces will consider it in terms of enabling access. Until that time, the access is available through the Special Access Program.
Well, if I may use my remaining time to provide some advice to you and to the minister with respect, I've had some very, very profoundly affecting meetings with cystic fibrosis patients in this country, and they need access to Trikafta immediately. So anything that this government can do to expedite and accelerate production of and a distribution of Trikafta beyond the special access program. Just generally, I would urge this government to do on an emergency basis. Thank you, Mr. Speaker or Mr. Chair.
Thank you, Mr. Davies. We go now to Ms. O'Connell. Ms. O'Connell, please go ahead, 5 minutes.
Thank you, Mr. Chair. And getting back to COVID and some of the areas that I think Canadians are really interested in, today was a big announcement in regards to vaccine deliveries. And Canada, as we know, is number one, I believe, in G7, G20, OECD for first doses, but getting into second doses, I know here in Ontario and in my community, we're getting those second doses out. And with today's announcement, perhaps through the chair to the minister, you could speak about the announcement today, where that puts us in terms of delivery and our position for getting Canadians fully vaccinated, especially in the context of the Delta variant.
Well, thank you very much, MP O'Connell, through the chair. And I'll say that today's announcement was indeed really great news. In fact, now we are on track to having 68 million doses in total delivered by the end of July, which is more than enough to fully vaccinate 33.2 million Canadians over the age of 12. So we've, of course, got some work to do to administer all those vaccines, but the news is good. And we hopefully will start to see the curve of the second vaccine dose rise as rapidly as the first has. I know that Canadians are very eager to get their second dose, and immunizers are very eager to get going.
Thank you. And I know there are many officials that are here that are actively work with procurement in terms of working to get these doses. So I won't have time to ask you all questions, but I think on behalf of all Canadians, thank you for your hard work in getting these doses. So maybe I'll just ask, since this news came out, to Brigadier General Brody, if you could even just give us a little bit of an update as in terms of the specific schedule of what's arrived, how many doses we received this week, and then what's anticipated in the next week or so based on the schedule that you have after this announcement. If you could just highlight for the committee this news.
Thank you, Mr. Chair and the honorable member. So this week alone, we have brought in 9.5 million doses of COVID-19 vaccines. We've distributed over 6 million doses of those, or will have by the end of today. Certainly another 2.7 million arrived this morning, and we'll continue to distribute vaccines as they flow into Canada and as the provinces pull those forward to support their vaccination campaigns. We're tracking for significant volumes of vaccines to continue flowing in every few days for the next several weeks until we reach the point where we have an appropriate number of vaccines to fully vaccinate all eligible Canadians.
Thank you. And what is that number for approximately all eligible Canadians? For the 2 doses, obviously.
Thank you, Mr. Chair and the honorable member. So if we're looking at 100% coverage from a vaccine distribution perspective, and that factors in a number of assumptions with respect to how we manage the inventory as it processes through the supply chain, we're looking at around 66 million doses to hit that 100% target. And clearly, Dr. Tam has encouraged us to shoot for the stars. So we are looking at encouraging Canadians to be vaccinated in the greatest measure possible so that we can achieve not only that 75% that will allow us to minimize the burdens on our hospital and our healthcare systems, but to truly protect Canada and Canadians in this environment and in this pandemic, and to see us through to the other side.
Thank you so much for that. Thank you, Mr. Chair.
Thank you, Ms. O'Connell. We go now to, on va maintenant à Monsieur Lemire.
We go now to Mr. Lemire. Mr. Lemire, go ahead, please, 2.5 minutes. Thank you, Mr. Chair. My question will be for Minister Hajdu. I liked a part of her answer when she said that all of the people that I mentioned, that it would be important to have them around a table. She said they've been consulted. Does she see the difference between consulting people and bringing them around a table so that together we can find the best possible strategy and dialogue about different expertise? Because what the government has done, if I'm thinking about the working group on COVID-19 vaccines, there was criticism based on the transparency and the ethics of some people around the table. What's important to me is ensuring that we work together, especially for the PMPRB. Research Canada has 4 recommendations on prudence to ensure the innovation and research ecosystem and to address the consequences on value for patients, access to drugs for patients, and jobs for the next generation of highly qualified researchers and having the funding there. They also suggest that the PMPRB's reform be postponed until there's a more complete process looking at the whole ecosystem by bringing together around the table all of the main stakeholders affected by the reform. What would the minister say in response to that?
Well, first of all, to the member, we have had a number of stakeholder consultations, but I'll turn to Dr. Lucas, who has details about the types of consultations that have gone on through the process of suggestions to reform PMPRB.
Thank you, Mr. Chair. There have been extensive consultations over many years regarding the patented medicine price review board and specifically the regulations, which came into force in August 2019. Subsequent to that, there's been extensive consultation on the guidelines to implement those through the PMPRB and in regard to the effect of the pandemic. Furthermore, through work of the Ministry of Health and the Ministry of Innovation, Science and Economic Development, we have been consulting the industry, patient groups, and others on the life sciences sector in this country, rejuvenating the biomanufacturing sector as outlined in the budget with an investment of $2.2 billion, and working on critical elements such as Dr. Strong referred to in terms of clinical trials.
I'd like to hear about transparency. Would that lead us to transparency? Will we see the fruit of those meetings?
The various consultation exercises have resulted in a variety of what we heard reports and documents provided. The Patented Medicine Price Review Board, for example, on their guidelines has provided revised guidelines. There's been multiple step consultations. Health Canada will be posting in the coming weeks a report on its consultations regarding this strategy for rare disease drugs. So there is a great deal of transparency in terms of the engagement.
Merci, Monsieur Lemire.
Thank you, Mr. Lemire.
Okay. We go, once again, we go back to Mr. Davies. Mr. Davies, go ahead, 2.5 minutes.
Thank you. Dr. Tam, federal modeling produced in May suggested that when 75% of eligible Canadians are fully vaccinated, restrictive public health measures like distancing and masking could begin to loosen. You recently confirmed that the variants used to develop those models did not include the Delta variant, which is the most infectious tract in Canada to date. In fact, you were quoted a few days ago saying, if we model the Delta variant now and put that into the model, it does mean that even higher vaccination coverage would be even better at protection against the hospitalizations and overwhelming the health system. Quick question, does PHAC plan to update its 75% full vaccination target in response to the spread of the highly transmissible Delta variant across Canada?
Well, in terms of modeling and data, yes, we'll be updating it. In terms of what benchmarks to use for policy decisions, the vaccine coverage is not the only benchmark. So the other really critical piece is the deceleration of this third wave in Canada. So you have to look at both. Otherwise, you'll be, taking just one side of the coin.
So in other words, would you agree that is what you're saying, Dr. Tam, that Canada will not be able to exclusively vaccinate its way out of a potential fourth wave driven by the Delta variant?
That's right. You still need to use a combination of measures, but with the vaccine, you can begin to take out certain layers as well. So that's what we'll be seeing. And with the Delta variant, the other key message is, of course, 75-20. That's their first goalpost, if you like. You have to, you can ease measures. You have to be very careful until you get 2 doses.
Right. Now, I want to put to you what's happening in the United Kingdom. There, the Delta variant has surpassed the Alpha variant to become the dominant strain. As a result, this week, Boris Johnson delayed his plans to lift most remaining COVID-19 restrictions by a month. One of the reasons, by the way, is because a study by Public Health England found that Pfizer and AstraZeneca vaccines were notably had lower effectiveness after 1 dose for the Delta variant at only 33% and 51% respectively. So he is saying that the extra time will be used to speed up Britain's vaccination program, which has already delivered full vaccine schedules to 44.5% of the population. Given that only 14% of Canadians have been fully vaccinated to date, do you believe that provincial reopening plans should be delayed to accelerate the delivery of second doses in response to the spread of the Delta variant?
I think the provinces have to manage based on their own epidemiology, which is quite different from one province to the other. Having said that, with the amount of vaccines coming in, I actually think that second dose coverage will accelerate pretty fast. So data, not dates, but in any case, even those initial ballparking of the dates from the different plans, even with the Delta variant, I think if we can get the vaccinations rates up, you may still be able to meet those kind of timelines.
Well,
some provinces deliberately didn't put certain dates, and other ones did, but with a caveat that they may have to change it if the need arises. We hope they don't.
Thank you, Mr. Davies.
Oh, thank you, Mr. Chair.
So thank you, committee. That wraps up our third round. We have a very few minutes left. Given that the House voted on estimates A last night, I think that us voting on it here, it becomes somewhat moot. So I suggest that we have a quick snap around, give every party 1 minute. So I will start with the Conservatives. Who's up for the Conservatives at this point? Mr. D'Entremont. Go ahead, Mr. D'Entremont. 1 minute, please.
Thank you. Quick question around AstraZeneca. Provinces have basically stopped using it. There's a challenge right now that if you travel to the States that they won't accept that as being your vaccine at this point. So maybe NACI has looked at more closely at what we're supposed to do with AstraZeneca doses. Have we ordered any more, maybe for the minister? And are we going to be canceling the contract with AstraZeneca?
In terms of the future of the contract with AstraZeneca, we've always been clear that doses that we don't use will be donated to the rest of the world through a variety of mechanisms. But I'll turn to Dr. Tam for the specifics on AstraZeneca and NACI.
Well, I think NACI's made these recommendations. Right now, what the detail work is done with the provinces and territories, who's coming back to, in fact, Brigadier General Brody, with the actual numbers of doses that they require. Some individuals still want AstraZeneca as their second dose. So provinces are making sure those doses are covered. But it is a very careful sort of monitoring that we need so that we do not order more than we need to, but at the same time satisfy that need. I don't think we will see the numbers sort of come to ground for a few days, probably, just to see what the initial shift in public requirements will turn out to be like after the update to the recommendations.
Thank you, Mr. D'Entremont. We go now to Mr. Kellaway. 1 minute, please.
Thank you, Chair. This is a question that can be answered by anyone. Could you tell us more about the strategies PHAC is using to monitor Canadians' immunity to COVID-19? That's question number one. And quite frankly, do you think Canadians should feel optimistic about the immunity levels and trends that we're seeing across the country? Thank you.
Well, perhaps I can turn to Dr. Tam, who is obviously an infectious disease expert and is widely connected to the research community.
Yes, there's been a very significant investment through the Canadian Immunity task force. Through that task force and its funding mechanisms, a whole host of studies and surveys are being done across Canada in the general population, in blood donors, more recently in persons with HIV, in seniors, in long-term care and healthcare workers, in kids. So we will have some very good data on the level of antibodies and immunity in the population. What I will say is prior to the vaccine, because we did manage to suppress a lot of transmission in Canada, the level of immunity from the actual natural infection was low. It would be less than 10% for the most part, and few percentage points when we started the beginning of the second wave, for example. But with vaccines and with the uptake in vaccines, it means that a very significant proportion of the population will now benefit and have immunity. The funding and the studies and the surveys will continue over time just to monitor the immunity afforded by the vaccine or the immunity afforded by the virus.
Thank you, Mr. Kellaway. Nous allons maintenant, Monsieur.
We go now to Mr. Lemire. Mr. Lemire, go ahead, please, 1 minute. Thank you, Mr. Chair. During our meeting, there was an important piece of news that all Canadians are extremely concerned. The lead coach of the Montreal Canadiens has COVID-19. Why am I mentioning this? Because the team has confirmed that he had the 2 doses of the vaccine. I'd like to ask Dr. Tam or someone else, how is it possible to get COVID-19 to test positive, and that has a major impact on the national interest? He already was vaccinated twice.
Yes, I think in this country we're very fortunate to actually have very effective vaccines, but vaccines are not 100% effective, even with 2 doses. Just to illustrate this, so if a vaccine is 80% effective, you might still get then a fifth of the population, even after vaccination, may be susceptible to infection. But what we do know is, in general, these infections are going to be milder. And so the prevention of serious outcomes is also very key. But what you've brought up is a very important point, which is you still can get infected. Even though you have a mild illness, you could pass it on to someone else who might not have been well vaccinated. But the bottom line still stay the same, whether it's the variants that we have now or the fact that you may still see cases after vaccination. The bottom line is still to get 2 doses of vaccine or complete a full course of vaccines. That will still work. Sports teams have to have protocols. And so at this time, these type of games are performed under the auspices of public health departments that have safety plans in place so that should someone become positive, they don't spread that virus to a lot of other people.
Merci, Monsieur.
Thank you.
Mr. Davies, 1 minute, please.
Well, I think we all can agree that we're all pulling for les Canadiens to win the Stanley Cup this year. So we'll get that on the record. Dr. Tam, we heard some evidence this week that highlighted the federal government's failure to duly consider sex differences in immune response to infections and vaccinations in our vaccination study. She noted that being female is the greatest predictive risk factor for most autoimmune diseases, and that women also bear the brunt of experiencing more severe adverse events related to vaccination. And we've seen that with COVID-19 vaccines. By the way, we also know that women have twice as many antibodies as men. Can you confirm if the Government of Canada is conducting sex-based dosing studies for these new gene delivery platform vaccines, and whether they're being performed for safety and efficacy?
I might start, but it may be Dr. Lucas who's in a better position to say this. All I do know is that the clinical trials and the recruitment of participants have included both male and females, and in a good proportion. But the trials that are done in tens of thousands can't scope in every single population group. So it's not just sex difference, there are other differences. So pregnant women, we need more studies in. in particular. We're following pregnant women through registries. So, but it is a very important point. In fact, through preclinical trials all the way to clinical trials, you need to take a sex-based approach, including animal studies even. But I think the regulators do have some requirements on this front.
Thank you, Mr. Davies. So that wraps up our questions. I'd like to go on record by saying that the chair takes no official position on hockey.
Well, Chair,
and, yes?
Actually, if I may, I would move that the committee actually wish the best to the Canadians in their upcoming endeavor.
I will second that, Chair.
Yeah.
Do we have unanimous consent?
I second.
Agreed.
I think we have unanimous consent for that. So
And,
thank you very much.
The price is right.
Yeah, and I guess we have unanimous consent that we don't need notice of motion for that as well. So actually, so that does bring us to an end. Thank you all very much for your time today. Most particularly, I want to thank the witnesses for once again giving us so much of your time and for so much of your hard work on an ongoing basis for some of you for years now, but certainly for the last 15 or 16 months. We really do appreciate it. Thank you for assisting us with our studies. And with that, we are now adjourned. Thank you all.